Hello.
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 Dr.
Yes,
Asha,
sir.
I have joined through mobile.
Yes, sir.
So I am trying to join through computer also, and if I am connected trying to join through computer also, and if I am connected trying to join through computer also, and if I am connected trying to join through computer also, and if I am connected trying to join through computer also, and if I am connected trying to join
Sir, your voice is going again. Sir, you are muted. Sir, your voice is going again. Sir, you are muted. Sir, your voice is going again. Sir, you are muted. Sir, your voice is going again. Sir, you are muted. Sir, your voice is going again. Sir, you are muted. Sir, your voice is going again. Sir, you are muted. Sir, your voice is going again. Hello.
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 Yes, ma'am.
Can everyone hear me, please?
Yes. Am I audible?
Yes, sir. Yes, sir.
Fine.
So,
I
sir,
have joined through
I'm
mobile
starting
only.
the program now.
Yes.
So, welcome to this 202nd episode of Happy Learning Masterclass. I'm Dr. Asha Jain, the past president, Raipur Society. I'm the convener, along with Dr. Rejeesh Ravi, who's the secretary of Calicut Obstetric Gynec Society. And I would like to introduce Dr. Rejeesh. He's the Secretary, Calicut Society, Foxy Quiz Committee Coordinator, South Zone, KFOG Academic Committee Chairperson, Organizing Secretary, Foxy South Zonal Conference, and a very, very active Foxian. Now, I would request everyone to join in the prayers before I invite Sir for his welcome address. We have two coordinators, Dr. Rekha Rajendrakumar ma'am, President of Bangalore Society, who is unable to join us right now because of an obstetric emergency. And we have Dr. Kalpana G from Malabar Medical College and Research Hospital, who has joined us. Now, I would request Dr. M.C.Patel, sir, whose brainchild is this Happy Learning series, and it has reached 202 now, to give his welcome address to officially welcome everyone present in this meeting. As we all know, sir is going for President Foxy this year, and he's very consistent, down to earth, and very approachable. So, requesting, sir, please give your welcome address, sir.
Thank you, Dr. Asha, for kind words. It gives me immense pleasure to welcome you all on to 202nd episode of Happy Learning Masterclass web series. And I welcome all the society who have joined this webinar, and all the president and secretary of respective society who have joined this webinar. Thrissur, Cochin, Palakkad,
Angamaly.
Sir is frozen. Sir is frozen. Sir, if you can hear us, if you would log out and log in again, please. He's frozen. So while Sir joins, I would like to introduce our guests of honor for the evening, Dr. Ashwath Kumar sir and Dr. Fessy Louis sir. Dr. Ashwath Kumar is an MD FICOG with a diploma in advanced laparoscopy from France, and he's an ICOG Governing Council member, IAG Managing Committee member in the past, Foxy Quiz Committee Chairperson. He was VP Foxy in 2019, VP KFOG 2017, past Secretary General KFOG. And the most important thing is, I've seen his videos online. He is so interested in teaching students and upgrading the level of obstetric gynec students that I'm really impressed. Welcome, sir. Welcome for your address.
Madam, can you hear me?
Yes, sir.
Yes, okay. Good evening, everybody. It is first of all, I thank M.C.Patel sir and Asha Jain madam for giving an opportunity to be chief guest of honor in this prestigious program of Happy Learning. This program has been going very well. I had participated in this program as speakers many times, as well as became as chairperson, guest of honor. Like one thing, it is the brainchild of M.C.Patel sir, who is a great visionary, and because of his efforts, so many all over India. We have all learned so many things. 270 episodes means how much effort he has taken, we can understand. I know him for the last 20 years while I studied in BJ Medical College, Ahmedabad. At that time itself, he was organizing the ASCOG, part of the organizing team of ASCOG at that time. He's a great administrator and an organizer. About coming to today's webinar, you have excellent speakers actually. You have, you can see you have the sessions on Hirsutism in adolescents, speaker Kartika. Then you have the POSCO, that is the most interesting part, the reverse panel with so many of our faculty will be discussing with M.C.Patel sir. I will be wished to see that. And then we have the talk by Elizabeth on adolescent, and we have many excellent speakers and as well as chairpersons, excellent chairpersons, all senior people. I am so happy that I am chairing along with Dr. Fessy, my close friend, and so many respected people are there. So without delay, I wish all the best for M.C.Patel sir as well as Asha Jain madam for their efforts, and hope that they will win the elections, and sir becomes a president and madam becomes a chairperson of the committee. Thank you so much. Thank you for the invitation. Thank you.
Thank you,
sir.
Dr.
Thank you so
Ashwath,
much.
for sparing time. And you are, of course, always with me in any of my academic activity. You are not less than my younger brother. So, welcome to this episode 202nd Epi Learning Masterclass. And just I was welcoming you all, and due to some network issue, my connection was interrupted. So, again, I would like to mention that have Thrissur, Cochin, Palakkad, Malanadu, and Angamaly Society have joined this webinar this time. And I welcome Dr. Fessy also. He is one more guest of honor. He is also a good friend of mine, and he is also with me in any of my academic activity. So welcome, Fessy. I also welcome today's learned speaker, Dr. Karthika. She is going to discuss about Hirsutism in adolescent. And to chair that very interesting session, I welcome Dr. Vinodini madam, Dr. Chandra madam, and Dr.Sibi Moi madam for the same. I also welcome all the learned panelists who are going to ask questions related to POSCO Act. Dr.Nishi Roshni madam, Dr.Muraleedharan sir, Dr. Manjunath, Dr.Maneesha, Dr.Latika Sukumaran, Dr.Lola Ramchandran madam, Dr. Parvati madam, and I also welcome second speaker for talk on Adolescent AUB, Dr.Elizabeth Jacob is going to discuss that very topic. And to chair that respective session, I also welcome Dr. Gracie Thomas madam, President Cochin, and Dr. Venugopal, past Secretary of KFOG, and Dr. Samarth Ram is good friend of mine and HOD of Sandhyaram Hospital at Palakkad. I also welcome Dr. Asha Jain. She is convener in this series since long, and Dr. Rejeesh has helped us a lot in all the webinars in state of Kerala. So welcome, Dr. Rejeesh. I also welcome Dr. Rekha Rajendrakumar, and rightly mentioned by Dr. Aja, she is stuck up in one emergency. She is a coordinator in this series since long, and Dr. Kalpana, she is also one of the coordinator for this webinar. And again, welcoming you all the president and secretary of joining society and all the delegates. When I started this series in era of COVID-19, I started with 2-3 friends, and now I am happy to announce that this is 202nd episode and 7,000 plus members as far as Happy Learning Masterclass web series is concerned. And we usually discuss focus topic every time and one panel related to that. So say for example, today we are going to discuss related to adolescent problem, AUB and Hirsutism, and same problem as far as sexual assaults are concerned. And pertaining to that, there is a POSCO Act and how it is relevant in our OBGYN practice, how we come across cases of POSCO in our practice, and what is our duty, we are going to discuss at the time of a panel. So with this, welcoming you all again. Thank you very much. Over to you, Asha.
Thank you, sir, for that welcome address. Thank you, Dr. Ashwath, for taking the time to be with us and giving your words of blessings and good wishes. Now, I would like to welcome Dr. Fessy Louis, sir, Professor and HOD, Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences, Cochin, Kerala. He was FOXI VP 2021-22, ESAR National Executive Member, ICOG Governing Council Member, VP Kerala Chapter IAG, Secretary Kerala Chapter ESAR, Reproductive Committee Chairperson KFOG, All India FOXI International Academic Exchange Committee Chairperson, and Secretary General, All Kerala KFOG. Member FIGO Reproductive Medicine Core Committee 2013-14, SAFOG. Welcome, sir.
Okay, madam.
Welcome.
Good evening to you all. I am happy to be invited for this Happy Learning series by the M.C.Patel sir. I think if you tell about Happy Learning series, I think we all know it is crossed 200. And as sir told, no, it is focused about some specific topic. The advantage is that if you want to learn about that specific topic, we can log into that. No, if you are really not interested, you need not. But specifically, you can enrich your knowledge on that specific topic. As sir told, today's topic is adolescence, and we have got a topic like a very relevant topic as Hirsutism, which we always say a managing dilemma for the gynecologists and among the adolescents practice, and also the adolescent AUB. However, we need to have about a lot of things, and POSCO Act. POSCO Act is very important. Unless we know that, we will, even gynecologists, I know few people have landed in trouble if you don't inform the authorities and if you don't know the details about this. So for that, we have got a wonderful reverse panel today. And today, I think, as you all know, it has been, this game is hats off to the conveners, Asha Jain madam and Rejeesh Ravi. Rejeesh is a good friend of mine, Asha Jain madam and M.C.Patel we know for more than 20 years. And it is well coordinated by Rekha madam and Kalpana madam. I think we have got excellent chairpersons also. I'm not going to repeat the names. We are all eager to hear from the speaker and the chairperson's words of wisdom, and also the reverse panel. We all look forward to that, because from the expert like M.C.Patel sir, we can hear the several points with that, and also the DUB AUB part. Dr. Elizabeth will be talking, and we got excellent chairpersons for that. So I hope that in further episodes we will be continuing. M.C.Patel sir will be continuing to enlighten us with the remaining whatever the relevant topics for specific topics, and this will be as before the previous episodes, very useful for practicing gynecologists and postgraduates for updating their knowledge. And thank you once again, M.C.Patel sir and Asha Jain madam, for inviting me, and also wishing all the best for your elections. And without wasting time, we can wishing all the best for this year. Thank you, and thanks all the Kerala Societies, Cochin, my parent society, President Grace Madam is Malanadu Society, Thrissur Society, Palakkad and Angamaly Society for coming in now, sharing their expertise and faculties, and hope this will be useful for all the attending gynecologists. Thank you for inviting me.
Thank you, Dr. Fessy, for sparing time for us. Of course, you are always with me in any of my academic activity. You are a good old friend. Thank you very much. Because in spite of odd situation and some health issues in family, you have joined this webinar. So thank you for the same.
Thank you, sir. Thank you for the wishes. Sir, with due permission, I would like to start the scientific session.
Yes.
So now we thank you all the dignitaries for joining in the inauguration ceremony. Now we take the program forward, and I would like to introduce our chairpersons, Dr. Vinodini, Dr. Chandra P, and Dr.Sibi Moi A, and I would request them to introduce the speaker and the topic, Hirsutism in Adolescents. So, Dr. Vinodini ma'am is an associate professor at Al-Azhar Medical College and Super Specialty Hospital, Ezalur. And welcome, Vinodini ma'am.
Thank you, ma'am.
Dr. Chandra P is working at Dees Hospital, consultant gynecologist, CA Hospital, Aluva, Kerala. Welcome, ma'am. We have Dr. Sibi Moi ma'am, who's a consultant gynecologist at District Hospital, Thodupuza. I hope I'm pronouncing it right. She is the former secretary of MOGS, graduation and post-graduation from Government Medical College, Calicut. And she's a member of FOXI, KFOG, MOGS, IMA, WIMA, and KGMOA. Her areas of interest are operative gynecology. So, well, over to you, respected chairpersons. to please introduce our speaker, Dr. Kartika, and also to introduce the topic, Hirsutism in adolescence.
Thank you, Asha Jain madam, for inviting us for this program. Thank you, M.C.Patel sir, for inviting us. And this program has been going on wonderful. Now, my duty is to introduce Dr. Kavita. Dr. Kavita, a young and enthusiastic gynecologist, is an alumni of Government Medical College, Kottayam. She did a master's from Thrissur Medical College in 2020, and she is already a fellow and diploma holder in minimum access surgery and is on her way to get her membership in Royal College. She has presented in AKCOG, UVA, Foxy, and Thricon. At present, she is working as a consultant in Midas Hospital and Surgical Center in Thrissur with keen interest in urogynecology and minimum access surgery. As you all know, today's topic is hirsutism in adolescents. That's one of the most intriguing and worrying symptom in young ladies because they're so conscious about their looks and their regularity of periods, because they keep discussing this with each other, and they find, in my practice, I find them so depressed sometimes that we all are very keen to know in detail and how to manage this thing. Okay, over to you, Dr. Kavita. I know she will enlighten us in detail. Over to you, Dr. Kavita.
Thank you, madam. Thank you for your kind words. So I'll first share
Just a second.
Okay, ma'am.
I would request Dr.Sibi Moi ma'am to say a few words about the topic while you start your sharing.
Okay, ma'am.
Good evening, all. At the outset, let me thank M.C.Patel sir and Asha Jain madam for inviting me to chair a session on adolescent hirsutism. Adolescent hirsutism, as we all know, is a common problem we come across in our day-to-day practice. Due to change in lifestyle, eating habits, and lack of physical exercise, adolescent hirsutism is showing a constant rise during the past few years. So today we have Dr. Kartika K, consultant gynecologist at Midas Hospital and Surgical Center, Thrissur, to speak on all the aspects of adolescent hirsutism. So I hand over the mic to Dr. Kartika.
Thank you, madam.
Okay.
Dr. Kartika, yeah.
Okay, ma'am. Good evening, everyone. Firstly, I would like to thank Dr. M.C.Patel sir and Dr. Asha Jain madam for giving me this opportunity. And today, the topic I'm presenting is hirsutism in adolescents. So if I'm audible and if there is no network issue, shall I continue?
Yes, please.
Okay.
You are very much audible.
Thank you. So firstly, I would like to rush through the basics. There are two types of hair, vellus hair and terminal hair. Vellus hair is fine, soft, short, unpigmented hair. It covers most of the body except for palms and soles. And in fetus or infants, this is also known as lanugo hair. Whereas terminal hair is long, coarse, and pigmented hair. It is found in scalp, legs, arms, and genitals in both men and women. And the pattern of distribution varies according to the gender. Coming to the definitions as such, excessive growth of terminal hair in a male pattern distribution on the face and body is known as hirsutism. It can also be defined as irreversible transformation of vellus hair to terminal hair. It affects between 5 to 10% of the women in reproductive age group. Hypertrichosis, it is the generalized overgrowth of soft fine vellus hair throughout the body. And virilization, it is a term used to describe the signs and symptoms of severe androgen excess that is characterized by deepening of the voice, temporal male pattern baldness, breast atrophy, increased muscle mass, and clitoromegaly. Coming to the hair growth cycle, it has three phases: anagen phase, that is the growth phase; Next is the catagen phase, during which the growth of the hair follicle is arrested. And last is the telogen phase, or the resting phase, following which there is shedding of hair. The length of the hair is determined by the length of the anagen phase. The scalp hair remains in anagen phase for 2 to 5 years and for a short time in telogen phase. Hence, the scalp hair tends to be longer. The hair follicles grow in asynchrony. That is, at a particular time, different hair follicles are at different phases of growth. The hair elsewhere on the body have short anagen phase and a long telogen phase, responsible for the stable length of the hair elsewhere on the body. In tenogen effluvium, large proportion of hair enter synchronously to the telogen phase, causing excessive shedding. These conditions can be precipitated by pregnancy, hormonal drugs, febrile illness, and severe psychological stress. This may lead to shedding of hair that lasts for 6 to 8 months, and this resolves when the asynchrony of the hair follicle growth is re-established. Now, coming to the effects of steroid hormones on the hair growth, androgen, especially the testosterone, it stimulates hair growth, increases the diameter and pigmentation of the hair, and it also increases the time hair follicle spends in anagen phase, except for the hair on the scalp. Estrogen, it slowers the growth of hair and causes the hair to be more finer and lighter. Progesterone, natural progesterone has no or little effect, whereas synthetic progesterone, especially 19-nor-testosterone derivatives, have androgen-like effect on the hair. In pregnancy, there is high concentrations of estrogen and progesterone, and this leads to synchrony among the hair follicles, resulting in a finite period of synchronized hair growth followed by shedding. So this was about the effect of androgens. Now coming to the androgens, major circulatory androgens in women. According to descending order of serum concentration, these are dihydroepiandrosterone sulfate, DHEA, androstenedione, testosterone, and dihydrotestosterone. The main source of androgens in the body in a woman are adrenal cortex and ovaries. DHEAS is almost exclusively secreted from the adrenal cortex, and other hormones secreted are 25% of the testosterone, 50% of the androstenedione, and 50% of DHEA, whereas ovary secretes 25% of the testosterone, 50% of the androstenedione, and 20% of DHEA. DHEAS, DHEA, and androstenedione, these three are pre-hormones. That is, they as such have no intrinsic androgenic properties, and they need to be converted to testosterone or dihydrotestosterone for their action. DHEAS, as I already mentioned, it is 100% secreted from the adrenals, and its serum concentration is about 100 to 350 microgram per deciliter. Normally, DHEA is secreted 50% from the adrenals, 20% from the ovaries, and about 30% from the peripheral conversion of DHEAS. Androstenedione is secreted 50% from the adrenals and 50% from the ovaries, whereas testosterone is secreted 25% by the adrenals, 25% of the testosterone is by the ovaries, and 50% is from the peripheral conversion of androstenedione. The normal serum concentration in a female is about 20 to 80 nanogram per deciliter. Dihydrotestosterone is produced only in the periphery by the intracellular conversion of testosterone by 5-alpha reductase enzyme. So in this diagram, it shows the total testosterone distribution in the serum. In men, in men and women, about majority of the testosterone is bound to sex hormone binding globulin. In men, 78% is bound and 3% is free or active. Whereas in normal women, 80% is bound to sex hormone binding globulin and 1% is the free form. Whereas in hirsute women, there is excessive production of androgen as well as hyperinsulinemia, which when present depresses the sex hormone binding globulin levels, increasing the free testosterone to 2%, even when the total testosterone levels remain within the normal range. So these are the few basic important things. Now coming to the causes per se, the most common cause for hirsutism is PCOS, which accounts for 70 to 80% of the cases. The second most common would be idiopathic hirsutism, which is thought to be due to increased 5-alpha reductase activities, and it accounts for 6 to 7% of the cases. The other causes include androgen secreting tumors, which are more of ovarian origin rather than adrenal origin. Yet another condition is non-classical congenital adrenal hyperplasia, which accounts for 1.5 to 2.5% of the cases. Then is Heron syndrome, that is hyperandrogenic insulin-resistant acanthosis nigricans syndrome. Then there can be rare genetic causes like Y chromosome mosaicism or incomplete androgen insensitivity, which can present with features of hyperandrogenism at puberty. While taking a history of drug usage like methyl testosterone, androgenic agents like danazol, glucocorticoids, phenytoin, diazoxide, cyclosporin, and minoxidil should also be asked. And least common causes can be Cushing's disease or Cushing's syndrome. Though this is not a common cause in adolescents, but I think it needs to be mentioned. The prevalence of Cushing's syndrome in hyperandrogenemia is less than 1%. And yet another condition we need to look out for is hyperprolactinemia. The mild cases of hyperprolactinemia can cause hirsutism. This is because prolactin has a stimulatory effect on the adrenals, leading to production of dihydroepiandrosterone sulfate, and this can cause hirsutism. So coming to the evaluation, in a large majority, PCOS or idiopathic hyperhirsutism is the cause. So evaluation is aimed at quantifying the severity and identifying few other causes that require additional specific evaluation and treatment. That can include hyperprolactinemia, congenital adrenal hyperplasia, and androgen secreting tumors. So an evaluation should begin with careful history, which the key points in history should include menstrual history, the age at onset of hirsutism and the rate of progression of hirsutism, other signs like acne, hair loss, other symptoms and signs of virilization. We have to ask about her family history, if anyone in her family has similar symptoms, and also regarding the medication history. So in the menstrual history, one needs to ask about the age at menarche to rule out whether there is any precocious puberty. Then they have to ask about the regularity of the cycles. If it is less than 8 cycles, it is considered as oligomenorrhea. Presence of premenstrual symptoms is suggestive of an ovulatory cycle, whereas in PCOD, we expect her to have an irregular cycles which occurs soon or at or soon after menarche. Although the clinical presentation of non-clinical congenital adrenal hyperplasia is similar to PCOS, hirsutism in such cases will present at a very early age. Also, we need to ask about the progression, the rate of progression of hirsutism. If it is rapid, it is more suggestive of an androgen secreting neoplasm. Also, there can be changes in menstrual pattern associated with weight fluctuations, so that needs to be taken into account. And family history of hirsutism, oligomenorrhea, obesity, and infertility can be pointed towards familial PCOS and non-classical congenital adrenal hyperplasia. So these are the things we have to keep in mind while taking a history. And next important thing is physical examination. Firstly, we have to calculate the BMI and also document the distribution and severity of hirsutism that can be done by modified Ferriman-Galway score. So in this, the score points from 0 to 4 are given for 9 sites. That includes upper lip, chin, upper chest, upper abdomen, lower abdomen, upper arm, thighs, upper and lower back. So the total score can vary from 0 to 36. According to X-ray, the cutoff is taken as a score of more than 4 to 6 can be defined as hirsutism. But in American text, especially in Spiroff and all, a score of more than or equal to 8 is defined as hirsutism, with a score between 8 to 15 taken as mild to moderate, and a score more than 15 considered as severe hirsutism. A physical examination should also look for signs of virilization. That includes acne, seborrhea, temporal balding, deepening of voice, muscular mass increase. We have to also look for whether there is breast atrophy and clitoromegaly. Clitoromegaly can be defined as a clitoral glans of more than 1 centimeter or a clitoral index, that is length times width, of more than 35 mm. Apart from that, we should also look for acanthosis nigricans. It is a sign which is suggestive of insulin resistance. And also look for abdominal or pelvic masses. It can be present positive in cases of androgen secreting tumors. Coming to the causes, PCOS is the most common cause. Hyperandrogenemia is the key diagnostic feature affecting around 60 to 100% of the women with PCOS. The diagnostic criteria or the Rotterdam criteria includes 2 out of the 3, that is anovulation or oligomenorrhea and clinical or biochemical evidence or ultrasound evidence. The Androgen Excess PCOS Society defines PCOS as either anovulation and oligomenorrhea along with clinical or biochemical evidence of hyperandrogenism, or as or with clinical or biochemical evidence of hyperandrogenism along with ultrasound evidence. So this is the diagnostic algorithm that is given in the recent X-ray. First step is to look for whether the female has irregular cycles along with clinical evidence of hyperandrogenism. Excluding other causes like thyroid disorders, hyperprolactinemia, non-classical CAH, and hypogonadotropic hypogonadism. If she has irregular cycles and clinical evidence of hyperandrogenism, she can be diagnosed as having PCOS. If there is no clinical evidence of hyperandrogenism, we have to do biochemical testing for hyperandrogenism. If that is positive, she can be diagnosed as having PCOS. If she presents only with irregular cycles or only with hyperandrogenism, in adolescents, an ultrasound or AMH is not indicated. It is done only in case of adults. What is the definition of irregular menstrual cycles? Normal in the first year post-menarche is which is taken as pubertal transition. If more than 1 year to less than 3 years post-menarche, the cycle duration of less than 21 days or more than 45 days is taken as irregular. For more than 3 years post-menarche to perimenopausal age, a cycle duration of less than 21 years to more than 35 days or less than 8 cycles per year is taken as irregular. And for more than 1 year post-menarche, more than 90 days for any one cycle can be taken as irregular. Clinical hyperandrogenism is in adolescents, it is characterized by severe acne and hirsutism. Whereas in adults, it is represented by acne, female pattern hair loss, that is hair loss mainly in the caput, as well as hirsutism. It is severity is assessed by modified Ferriman-Galway scoring, and a score of more than or equal to 4 to 6 is taken as hirsutism. Biochemical hyperandrogenism is assessed using total testosterone and free testosterone levels. If this is not elevated, then androstenedione and dihydroepiandrosterone sulfate levels should be measured. Ultrasound diagnosis of polycystic ovarian morphology. When the woman presents with irregular menses and hyperandrogenism, an ovarian ultrasound is not necessary for the diagnosis. And it should not be done for PCOS diagnosis in adolescents. However, it can be done in adults in which transvaginal ultrasound approach is a preferred method using an 8 megahertz transducer. The the threshold is described as a follicle number per ovary of more than or equal to 20 or an ovarian volume of more than or equal to 10 ml on either ovary. Serum AMH levels could also be used for defining the polycystic ovarian morphology in adults, and a level of more than or equal to 5 nanogram is taken as a cutoff. Yet another cause for hirsutism is Heron syndrome, that is hyperandrogenic insulin-resistant acanthosis nigricans syndrome. The primary pathology in this case is severe insulin resistance, and the female presents with acanthosis nigricans, that is a gray or brown velvety appearance on especially in the nape of neck, axillary and groin areas. Hyperinsulinemia is due to insulin resistance, stimulates the ovarian androgen production in the theca cells and also decreases the sex hormone binding globulin levels, thereby leading to an increase in the free testosterone levels, which can lead to virilization. This is associated in severe cases. This can be associated with the ovarian stromal hyperthecosis, which is a histological diagnosis. And in severe cases, the patient typically presents as obese, severely hirsute, and virilized. And these females tend to have a serum testosterone level of more than 150 nanogram per deciliter in severe cases. Idiopathic hirsutism. Hirsutism with regular menses and normal serum androgens, this should be an idiopathic hirsutism should be suspected. This is thought to be due to an increased peripheral 5-alpha reductase activity. The other cause for hirsutism is congenital adrenal hyperplasia. It is caused by adrenal steroidogenic enzyme deficiencies that leads to excessive androgen production. This disorder is inherited in an autosomal recessive fashion. So this is a flow chart. ACTH acts on the adrenal glands where the cholesterol is converted to pregnenolone and 17-hydroxypregnenolone. This is further acted by the enzymes. The first enzyme to act is 3-beta-hydroxysteroid dehydrogenase, which converts pregnenolone to progesterone, and 17-hydroxypregnenolone to 7-hydroxyprogesterone. This is further acted upon by 21-hydroxylase enzyme, which converts progesterone to deoxycorticosterone and 17-hydroxyprogesterone to 11-deoxycortisol. This deoxycorticosterone, which is the mineraloid corticoid pathway, in which the next enzyme 11-beta-hydroxylase acts and converts it into corticosterone and aldosterone. Whereas in the glucocorticoid pathway, 11-deoxycortisol is converted to cortisol by the same enzyme. So, if there is deficiency of any of these enzymes, this can lead to a block in the pathway, and the precursors are then directed towards sex or steroid hormone pathway. So, the main pathophysiology in congenital adrenal hyperplasia is due to reduction in the cortisol, which in turn stimulates ACTH production, causing adrenal hyperplasia. So the most common enzyme deficiency is 21-hydroxylase deficiency. And the other hormone deficiencies are 11-beta-hydroxylase and 3-beta-hydroxysteroid dehydrogenase. The patient usually presents with early onset hirsutism or early onset premature adrenarche. She has a history of rapid early childhood growth with advanced skeletal age and truncated final height. The menstrual disorders in these females resemble PCOS very closely. So all patients presenting with PCOS-like phenotype it is recommended to be screened before diagnosis of a PCOS is made. So this must be suspected. Non-classical type of congenital adrenal hyperplasia should be suspected if there is early onset hirsutism, if there is premature adrenarche, or when there is a positive family history, or if she is of a high-risk ethnic group, that includes Ashkenazis, Jews, the Mexican population, and the Slavic-speaking community. So when suspecting non-classical CAH, the screening test done is early morning serum 17-hydroxypregnenolone. If the levels are more than or equal to 200 nanogram, it should be confirmed with ACTH stimulation test or cosentropin stimulation test. The next cause of hyperandrogenism is androgen secreting tumors. This is a rare condition, and ovarian causes of androgen secreting tumors are more common than adrenal causes. The prevalence of ovarian androgen producing tumors is between 1 in 300 to 1 in 1000. Tumors that can cause hyperandrogenism include Sertoli cell, Leydig cell tumors, lipid and theca cell tumors, and Hylas cell tumors. Adrenal tumors are rare. If they are present, they are mostly malignant, and usually along with hyperandrogenism, there will be increased cortisol levels as well. Androgen secreting tumors almost always present with rapidly progressive hirsutism or with signs and symptoms of virilization. So suspect this, a proper history and physical examination is essential. And along with this, the serum testosterone levels can be assessed, which is always more than 150 nanogram per deciliter. Coming to the investigations as such, the relationship between hirsutism and circulating androgen levels is unclear. Only 50% of mild hirsutism cases will have an increase in the free testosterone levels. Also, a third of the women with moderately elevated free testosterone have no hirsutism. So, laboratory evaluation is not indicated in all women with hirsutism. So, whom to evaluate? So, the women with moderate to severe hirsutism, or in women with sudden onset, women or girls with sudden onset hirsutism, rapidly progressive hirsutism, and if there is association with virilization. So these are the candidates for further laboratory evaluation. There no testing needs to be done for isolated mild hirsutism. Then specific investigations to define the cause. Serum testosterone, it is the best test for measure of overall androgen production. It is the most reliable when it is taken early morning in the follicular phase. And a concentration of more than 150 nanogram per deciliter is almost always is predictive of androgen secreting tumors. It has a low positive predictive value. That is, even if the levels are more than 150, it is not always necessary that she has a tumor. And it has a high negative predictive value. That is, in case of tumors, the level will mostly be more than 100% be more than 150 nanogram per deciliter. Then the next test is DHEAS. It is the direct measure of adrenal androgen production, because as I've already mentioned, DHEAS is exclusively produced by adrenals. Though ESHRE does not advise measuring of DHEAS as a first line for diagnosing PCOS, but American Androgen Access PCOS Society recommends measuring DHEAS levels for diagnosis of PCOS as well. A level of more than 700 nanogram per deciliter is usually found in adrenal androgen secreting tumors. The next test is 17-hydroxypregnenolone test. It is a screening test for candidates where we have suspicion of non-classical varieties of congenital adrenal hyperplasia. Yet another possibility is Cushing syndrome. Though this is very rare, I would like to mention the screening test for Cushing syndrome. Either of the three tests, that is 24-hour urine cortisol excretion or late nights salivary cortisol test or overnight dexamethasone suppression test, can be done as a part of screening for Cushing syndrome. In the Cushing syndrome usually present similar to PCOS-like symptoms, that is irregular cycles, early onset hirsutism, but there will be associated features of hypercortisolism also. That is, there will be features of central obesity, there will be moon-like faces, fat deposition on the nape of neck, there will be easy bruising, and purple striations can be found on the abdomen and flanks. Associated features like hypertension, etc. can also be present. So these are the features that point towards Cushing syndrome, and such candidates only we need to perform these tests. Also, an ultrasound can be performed if adrenal or ovarian tumors leading to hyperandrogenism can be suspected. But it is not always necessary that a tumor can be detected on an ultrasound. This is a flow chart which summarizes the management. If there is hirsutism, if it is mild with irregular menses, PCOS is the most common cause. If the cycles are regular, an idiopathic cause of hirsutism is suspected. If it is moderate to severe hirsutism, a total testosterone level should be measured. If the levels are less than 150 nanogram per deciliter, and it is a slowly progressive hirsutism, again PCOS is the cause. If it is rapidly progressive hirsutism with or without virilization, a transvaginal ultrasonography is should be done. If it is if there is a tumor that can be detected, then it is taken as tumors. If transvaginal ultrasonography is normal, an adrenal CT can be done. If it is normal and still there is a suspicion for tumor, then the ovarian venous catheterization, that is it is not usually done. Here, what is done is the ovarian veins of both right and left are catheterized, and the serum testosterone levels are measured, and the right to left testosterone gradient is taken. If the right to left testosterone gradient is more than 1.4, it is positive for ovarian testosterone producing tumors. If the left to right gradient is more than 15, it is considered positive for left side. If no gradient is seen, then severe, or if there is low suspicion for tumor, severe insulin resistance is mostly the cause. So this was all about how the how to come about the diagnosis.
Dr. Karthika, you need to
Yes,
wind
ma'am.
up here. It's been too long.
Can you take 5 more minutes, ma'am?
Yeah, because you've already been 35 minutes.
Oh, very sorry. I'll just go with the treatment. The treatment, if the woman judges herself to be hirsute, she requires treatment even if she is a case of mild hirsutism. The first line of treatment is estrogen plus progesterone oral contraceptive pills. The other drugs that can be used are anti-androgens like spironolactone, cyproterone acetate, flutamide, and finasteride. Estrogen and progesterone pill act by suppression of the LH and excuse me, madam, just a minute. Sorry. This progesterone pills, they suppress the pituitary LH by negative feedback, and the estrogen stimulates the hepatic sex hormone binding globulin production. Cyproterone acetate and drospirenone, that are anti-androgenic progesterone, these are the preferred drugs. This is because the recent data has demonstrated superiority of drospirenone containing contraceptives against hyperandrogenism. And subjectively, about 60 to 100% of the women report improvement in their hirsutism during treatment with oral contraceptives. Spironolactone is yet another drug. It is an aldosterone and androgen receptor antagonist. It also inhibits ovarian and adrenal androgen synthesis. The dose is 50 to 100 milligram twice daily, and maximum effect of all drugs used for hirsutism is attained at 6 months. So the therapy has to be continued for more than 6 months to achieve an effect. Then ciprotenone acetate, it is a derivative of 17-alpha hydroxyprogesterone. It is used in combination with ethinyl estradiol. It is a competitive androgen receptor antagonist. Next is flutamide. It is not used nowadays because it is expensive and causes severe hepatotoxicity. Yet another drug is finasteride. It is a 5-alpha reductase inhibitor. It blocks the conversion of testosterone to dihydrotestosterone. Now, there are 2 forms of 5-alpha reductase, and this finasteride acts mainly on form 2. So it has to be given cautiously if taken in pregnancy. This can cause ambiguous genitalia. So the mainstay of medical management is estrogen and progesterone, with the use of addition of anti-androgen as a second line approximately after 6 months if the desired effect is not achieved. Other options are GnRH agonist, but this is only for women whom other management has failed, and glucocorticoids in cases of symptomatic cases of NCCAH. Yet another topical cream is F-norethicone hydrochloride, a topical application twice daily for mild hirsute women. It is an inhibitor of ornithine decarboxylase. It gives improvement within weeks, but the problem is it reverts back to pre-treatment levels within 8 weeks of stopping the drug. Then other methods of hair removal is temporary methods like plucking, waxing, shaving, bleaching, and depilator uses. Whereas permanent methods like electrolysis and photoepilation can also be used. So to summarize, PCOS is most common cause of hirsutism in adolescents. Modified Ferriman-Galway score is used to grade the presence and severity of hirsutism. Laboratory evaluation is recommended in cases of moderate or severe hirsutism, sudden onset hirsutism, rapidly progressive or associated with symptoms or signs of virilization. Low dose estrogen plus progesterone is the first line of choice. And permanent hair removal method is best postponed until hormonal suppression has achieved maximum effect. Thank you. Sorry, ma'am, it took more than what was allotted to me.
Thank you, Kavita, for that elaborate presentation. You took a long time, but it was really worth it. I think lastly you had to little hurry up. It was okay. It's okay. It's okay. What I have to say is, what would you do in your primary investigation? An adolescent, around 13-14-year-old girl coming with, she's saying she's got some moose, she's got some hair on her chin. You're not audible.
Adolescent, 13 years of age, when she's having hirsutism, that is the clinical signs of hyperandrogenism is present. And I will now take a history to ask whether her cycles are regular. If these 2 factors are present, then it is a pointer towards PCOD. No further investigations need to be done. A diagnosis of PCOD can be made at this point. And yes, ma'am.
She's very worried about this hair growth because her classmates, they're teasing her.
Yes, ma'am. So I will start her on combined oral contraceptive pills. Preferred will be a pill with drospirenone, and a pill given should be given for at least 6 months to have an effect. It will help with her cycles also if she's having an irregular cycle.
Chandra ma'am, would you like to say something?
Yeah.
Yes. Yes, I would tell she is only 13 years and she is worried about the
ഏതാ അല്ലെങ്കിൽ അവിടെ എനിക്കൊരു ശകല നേരം കൂടെ എനിക്ക് വേണം ഇവിടെ സംസാരിക്കാൻ, അരമണിക്കൂർ. അവിടെ അല്ല, നീ ഒരു ശകലം മറിമായ എന്തെങ്കിലും ഒന്ന് കാണിക്കും കുറച്ചു നേരത്തേക്ക്.
Dr. Karthika,
Yes, ma'am.
can I ask one question?
Yes, ma'am.
You said ultrasound is not indicated in adolescents to diagnose PCOS if she has an irregular cycle and hyperandrogenism.
Yes, ma'am.
But there are other causes for hirsutism like tumors, congenital adrenal hyperplasia, all these things. So how you will diagnose without an ultrasound?
Mostly when she is usually presenting with tumors, the history will be having a sudden onset or a rapidly progressive hirsutism. So, or if she is having a family history. So, in such cases, I will suspect an ovarian or adrenal tumor, and for her, I'll definitely perform an ultrasound.
Sorry, ma'am, I will really have to interrupt because we have only 1 hour program left and we have one talk and panel left. So we cannot carry this further. I'm really sorry. So thank you so much, chairpersons. Thank you, Karthika. But we'll have to take the program forward. I'm sorry. Any final comment, Chandra ma'am, that you have? And then I'll proceed with the panel.
That's fine.
Yeah, she has covered it in a very elaborate way. But what I feel in when it is pertaining to our gynecological society, I thought the main factor reason for the hirsutism in an adolescent girl, we have to go more about the practical aspect of treating the adolescent PCOS and hirsutism, which is not outside, not from other departments. Like when we have to rule out all those things, and then we have to concentrate on how we deal with the adolescent hirsutism in an adolescent girl in our department. So I was thinking it's more in terms of polycystic ovarian disease, and which is that has to be given more importance, I thought. But it is a very good talk what Karthika did, but it was very much elaborate for our talk, our department. That's what I was thinking.
Thank you, ma'am. Patel sir, are you there?
Yes,
Hello?
I am very much there.
Yes, sir. So, sir, I would like to start the panel.
Oh, yes.
And we will have to finish it in 45 minutes.
Oh, yes.
So these are our panelists, whom I will be introducing one by one. And I take pleasure in introducing M.C.Patel, sir, a consultant obstetrician, gynecologist, and medical legal counselor, VP FOXY 2018, organizing secretary IICOG 2017, chairperson ethics and medical legal committee FOXY 2011 to 13. And once he became a medical legal committee chair, he has remained a medical legal specialist and a bedside comfort to every person who has landed in any kind of medical legal trouble throughout India. So hats off to that, sir. He is the honorary secretary of SOGOG, organizing chairperson MMCon, honorary member of State PCPNDT Committee, President Ahmedabad Society in the past, and President IMA branch, many things to credit. But more than everything, he is very consistent, he's very approachable, and he will continue helping you irrespective of what goes wrong. For the last 21 years, he's been going to the Northeast and giving treatment to underprivileged women over there. 21 years is what he's been doing. So welcome, sir. Here is a short appeal from sir. Please vote 10 a.m. 1st August 24 to 5th p.m. 10th August 24. Sir is standing for President Foxy. Please do vote. That's me. And I request your vote for committee chair. And here is a short appeal from sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
Slide, sir.
So, sir, before I start the panel proper, I would like to ask you a question. That POSCO is a new law. Is it worth discussing?
Yes.
We are gynecologists. We deal with adult women. Do we need to discuss it?
Yes. POSCO Act was enacted in 2012 and in 2019 some amendment came. And we gynecologists many a time are first point of concern as far as this type of cases are brought to us. Say for example, many a time small girl is brought to us with her mother with some common complaint like itching vulva or so. And we came to know that she is a case of STD, and on further interrogation, she gave history of exposure to her boyfriend. And in this situation, it becomes a case of POSCO, and we have to inform police. So this type of situation we face in our day-to-day practice, and that is why this act needs to be discussed at length, and how we encounter any problem related to this act in our day-to-day practice, and why we should be very vigilant not to end up into any litigation related to that. And that is why it is very important to discuss. And as far as medico-legal consequences are concerned, we gynecologists rank first as far as any medico-legal problems are concerned. Of course, POSCO is one of them, but other than POSCO, CPA or cases related to PNDT, cases related to MTP, cases related to ART. So with all this, we are in a bad situation that we should be aware of all the provisions of this law when we practice OBGYN. And that is why it is very important to discuss.
Thank you, sir. Now, I would like to invite Dr.Nishi Roshni, ma'am, Professor and HOD Obstetrics and Gynae at Government Medical College, Thrissur. She has previously been the president of TOGS Thrissur, Chairperson Indian Medical Association Wing, VP IMA, VP Diabetic Club, Secretary Editor TOGS, and now she is the president of Thrissur Diabetic Club, MEU Government Medical College Thrissur, IEC Government Medical College Thrissur. Her fields of interest are high-risk obstetrics, vaginal surgeries, and oncology. Her hobbies are music, reading, watching films, dancing, and singing. So over to you, ma'am, for your first question.
Thank you, M.C.Patel sir and Asha Jain madam for this wonderful opportunity for being a part of this very important medical issue that is POSCO Act. I want to know who is a child. Second, I want to know what is POSCO.
So under POSCO Act, any person less than 18 is child. And as far as this POSCO Act is concerned, just I mentioned that it was enacted in 2012 and it addresses all the sexual offenses related to children, whether it is sexual harassment, whether it is sexual assault, whether it is aggravated form of sexual assault, whether it is penetrative form of sexual assault, whether it is aggravated form of penetrative sexual offense, and use of child in pornography. These are the areas as far as POSCO Act is concerned. And for this type of cases, there is a special juvenile system of proceeding with the case, and police station and juvenile police station many a time, and CWC, that is Child Welfare Committee. So under POSCO, all these organization works to detect cases related to sexual offense to children. Yes, next.
Does this POXO Act cover sexual exploitation or offenses against boys also?
Yes, yes. It is gender equal. So it addresses both male and female.
Okay, so that is gender neutral, no, sir? Gender neutral.
Yes, yes.
So what are the punishment that is being given for these sexual offenses against this child?
So we do not want to go into detail as far as punishment part is concerned, but it ranges from 3 years of imprisonment and fine of rupees 3 lakhs to 5 lakhs to lifetime of imprisonment as per the case. Because say for example, under this amendment which came in 2019, and in that very amendment it was mentioned, when child is less than 16 years and when more than one person is involved in sexual activity, then all the persons involved will be taken as a accused, considering furtherance of common intention in constitute crime. And in this, there is a provision of imprisonment of lifetime. And one more area, in case of when child is less than 12 years, and in this same situation, even there is a provision for death sentence also. So from 3 years to death sentence is the punishment as far as contravention of provision of POXO Act is concerned.
So, sir, you have to report all these offenses,
yes.
no?
We will discuss that also.
Okay, okay. So, what are the offenses under child pornography and what are the punishment?
Yes, in this, if child is used in pornography, then there is a separate provision with that very person, and life imprisonment for 3 years to some 3 lakhs rupees of the fine. But when that person is also involved in pornographic activity, then again sexual assault, penetrative form of sexual assault will be charged to that very person. So if child is used for pornographic purpose and if child is made to be used in pornographic purpose with another child, then there is a separate provision. But any person who is involved in active activity as far as pornography is concerned, they will be punished vigorously.
So separate punishment for each?
Yes.
Yes. Okay.
Section 3, 5, 7, 9 of POXO, and in contravention of any act, there is a separate provision for punishment.
Okay, thank you, sir.
Yes.
Thank you, sir. Thank you, ma'am.
Yes.
Now we have Dr. Muraleedharan PD, sir. He is an assistant professor, has more than 9 years of experience and has many journal publications, many achievements, and he likes traveling and music. So over to you, Muraleedharan, sir.
Good evening, sir.
Good evening, welcome.
So you are describing about some of the recent amendments in POXO Act. Can you explain what was the recent amendment?
So just I mentioned, there was amendment in 2019, and in that very amendment, I mentioned about 16, less than 16 and less than 12 years. But one more thing, as far as amendment in POXO Act and amendment in IPC, the one more punishment was abatement. When any person instigate anybody or help anybody or aids anybody to constitute crime under POXO Act, then punishment will be much harsh. It is also there in POXO Act. And as far as amendment in IPC is concerned, section 376D and 376D, in that very section, it was amended that if child is less than 12, there is a provision of death sentence also. And if child is less than 16 and more than one person is involved, then all the person will be taken as a accused in a furtherance of common intention, and they could be punishable till lifetime imprisonment. So this amendment came in 2019. Yes, next.
Hello.
Yes, welcome.
Next, we have Manjunath Sir, Associate Professor at Al-Azhar Medical College, Kerala. He likes to read newspapers and enjoys nature. So welcome, sir. Over to you.
Madam, thank you. Thank you very much. I would like to say good evening to all of you. And let us go ahead with the discussion that we are planning to have. Sir, I would like to ask you a question. What do you mean by a sexual assault in a child?
Yes.
Sir, what does this constitutes about? Because in a children, we don't know what is what. They also don't know what, I mean, when such acts happen to them, we don't know how to deal with that. So what do you mean by a sexual assault or a sexual harassment or a pornography of a children, of a child?
Yes.
When we deal about, when
as
we
far
think
as sexual assault is concerned, in all this provision of POSCO Act, one common word is used, that is sexual intent. If any person with sexual intent touches child on her breast or her vagina or any part of perineum or so, or makes child to do so with any other child or to do so with him or her, it becomes a case of sexual assault. No need for any penetration, because penetrative sexual assault is a different entity. But merely touching this is constitute sexual assault. And as far as the aggravated form is concerned, when person is in a position of trust, then it becomes a aggravated form of sexual assault. Say, for example, senior family member in the family, school teacher in school, doctor in hospital, police officer in police station. So these are persons in a position of trust. And if they go with any sexual assault, then it becomes an aggravated form of sexual assault, and it is more punishable as far as these POSCO Act provisions are concerned.
Sir, can I interrupt you for a while?
Yes.
Sir, you mean to say that when sexual act has been committed by the professionals like teachers and doctors and other people, it going to become automatically, it is going to become aggravated form of sexual assault?
Any person in position of trust.
Okay, sir, how this can be misused, sir, in the private practice? Because this is POSCO Act is not entirely is not ours, but how it can impact the gynecological practice of a male practitioner?
Whenever any child is brought to us for any complaint, we usually examine that child in presence of relative and naturally one female nurse. So usually for doctor, this kind of allegation usually doesn't happen, that a doctor touches a part with sexual intent or so. But this is specifically for other persons in family, in school, in police station, or in hospital. Say, for example, staff of hospital also, they may be also could be involved in this type of activity, and they are punishable under this act.
Sir, the basic, there should be an intention from anybody.
Sexual intent, what is used?
Yes.
So it is to be proved. There should be sexual intent.
Yes, sir. As you said, we don't examine the child alone. We always keep a female,
exactly. So usually this kind of allegation is very rare.
Attender, bystanders nearby, then only we can examine. Of course, after taking a proper consent and maintaining the privacy of a child. Sir, what do you mean by actually a penetrative sexual assault? Which already
as far as penetrative sexual assault is concerned, again with sexual intent, any person penetrates finger, any article, penis, in vagina, in anus, in any other orifice with sexual intent, then it becomes a penetrative sexual assault. Or he makes other person to do so, or he makes child to do so with another child, then it becomes a penetrative sexual assault. And same way, when he is in a position of trust, it becomes a aggravated penetrative sexual assault.
Okay, sir, what is the aggravated, the counterpart of this penetrative sexual assault when it has been done by any of the professionals?
Yes,
like doctor
again,
or a
same.
police or a
In family, in school, school teacher, in police station officer, or in hospital, doctor or staff, when they are in a position of trust, and if they go with penetrative sexual assault, it becomes a aggravated form in eye of law, and this is more stringently punishable.
Okay, sir.
Yes.
Thank you for a beautiful answer, sir. Sir, then how shall we deal a case of a sexual assault? Suppose if I'm sitting in an OPD, if a case comes to me, how should I deal with the case, sir? How should I go about the case?
So, as such, whenever this type of patients are brought to us, I don't know whether this question is going to come or not, but we have to examine that very patient. We have to treat that very patient if treatment is needed. We have to form opinion. We have to collect evidences, and we have to inform police in this type of situation. If patient is brought by police only, it's fine. Otherwise, we have to inform police. And we are first point of contact to form opinion whether that child is assaulted with sexual offense or he is being assaulted more than once. So we have to form our opinion in this type of situation.
Sir, thank you for your answer. And how to examine a patient, sir? Let us say that I have got a patient which has been brought from the police station. So how shall I examine the patient? Because she is a child, she don't understand anything.
Yes,
so,
yes.
I mean,
So,
a case
Asha, is this question coming, or should I take at this time only?
Okay, sir. Okay, we should keep the parents nearby and also the sister nearby and explain to them.
We will
Sir,
discuss.
what
If this
sir,
question
what
is asked by any other panelist, then we will discuss this at the end of a panel, not to have repetition.
Okay. Sir, I think committing a sexual assault is one crime and videographing is another crime. Madam, can we go ahead, madam, for a
Yes,
while?
yes, Dr. Asha.
Yes,
Dr.
sir.
Asha.
Yes, sir.
Yes.
Now we have Dr. Maneesha. She's a consultant obstetrician and gynecologist at St. Joseph's Hospital, Dharmagiri, Ernakulam. So, welcome, Dr. Maneesha. She is interested in adolescent health education and infertility. Over to you, Maneesha, ma'am.
Thank you, madam. Thank you so much. Good evening, Dr. Patel.
Thank you, madam.
As an expert witness case of sexual assault, can you please ask me answer my question?
Sexual assault we have already discussed, and as far as this sexual harassment part is concerned, again in this in POSCO Act, it is very specifically defined that with sexual intent, if anybody utters any word or show any sign or follow the person with sexual intent, then it becomes a case of sexual harassment, or make other person to do so, it becomes a sexual harassment. In this situation, no need to touch even then it becomes a case of sexual harassment. Uttering some word or making some sign or following a person becomes an act of sexual harassment.
Okay.
Yes. Next.
Next, we have, sir, Dr.Latika Sukumaran, ma'am. She is UG PG from Surat Medical College, and she has a passion for dance and music, trained in Bharatnatyam, Mohiniyattam, Karnataka music, has Nritya Jyoti title from Mudra Indian School of Classical Dances. She is doing a dance drama for HPV vaccination project for public awareness. So these are all the images, sir.
Yes.
So you can see
Welcome.
she is
Welcome,
a
Latika.
very active person. Over to you, Latika, ma'am.
Latika, swagat je.
Yes. Good evening, all.
Good evening.
Namaste, Patel sir and
Namaste,
Asha
namaste.
madam.
Yes.
Angamaly Society આપનું હાર્દિક સ્વાગત કરે છે.
ધન્યવાદ.
Thank you for including me in this webinar.
ધન્યવાદ.
My question is, a 17-year-old girl comes with her boyfriend. She asks for contraceptive advice. So what will we do? What can be our advice to her?
So it is a very tricky situation when she is less than 18. She is minor and when she asks for contraceptive advice, many times it happens, they will come with a boyfriend and they will ask, and we are going to start our active sexual life, and we do not want to end up into any unwanted pregnancy. So please advise what to do. So there are two issues in this. One part is ethical part. If we do not guide them, if we do not advise them, and if they have decided, then they will end up into pregnancy. Again, they will come to us only for termination of pregnancy. But at the other side, there is a question of law. Because if we advise them any contraception, we are encouraging them to constitute crime in eye of law. Because it becomes a case of abatement. What is abatement? To instigate any person to constitute crime, to help any person to constitute crime, or to aid any person to constitute crime. So when we advise contraceptive advice, they will be encouraged to go for active sexual life, and it becomes a contravention of POSCO Act. So as such, we can guide them what is sexual health education, etc. But we cannot prescribe, because once we prescribe, then it becomes evidence, and if investigating officer is harsh one, they may harass us merely on ground of prescribing contraceptive devices. Of course, for any medical reason, say for example, if she have come up with AUB or so, and if you have advised contraceptive pill, it's another thing, because it is a part of treatment. But merely for contraceptive measures, if you advise any contraceptives, then it becomes a breach of this POSCO Act. So better not to prescribe on paper.
Thank you, sir.
Next.
Now we have Lola Ramchandran, ma'am, sir. She is the professor and unit chief at Jubilee Mission Medical College and Research Institute, past president of Thrissur Society, and has many other interests. She is interested in quizzing, trekking, and reading. And see here, she also won 12.5 lakhs in the Malayali Kaun Banega Karodpati. So, welcome, Lola, ma'am. Over to you.
Good evening, everybody. Thank you for the kind introduction. Now, my question to sir is, a 16-year-old girl is brought by her mother with a complaint of vulvovaginitis with discharge per vagina. Now, when you examine, you find that it is a case of sexually transmitted disease. And then when you ask, she says she has had a history of sexual exposure with a boyfriend. So what will you do?
Naturally, we have to treat that very patient. When patient is brought to us for vulvovaginitis or itching vulva and discharge per vagina, and if it is a case of sexually transmitted disease, then naturally we have to treat. But at the same time, when she is 16 years, she is minor, and it becomes a case of POSCO, we have to inform police.
Yeah, we will have to inform, no, sir?
Yes.
Yes, sir. When she is minor. Thank you, sir.
Yes. Yes, next.
Next, we have Sir Dr. Parvati from Cochin. She is a senior consultant at Devi Hospital. So, over to you, Parvati, ma'am.
Good evening, sir. Good evening, madam. My question is, an 18 years and 6 months old married girl is brought by her mother with pregnancy at 39 weeks, and they are insisting for LSCS. So, what will you do? How should we proceed? Will you proceed with LSCS if indicated?
Yes.
And is there an issue of child marriage? That is, she became pregnant before she was 18 years.
Yes.
So
it is very clear that as on this time of the cesarean section, she is major, 18 plus 6 months. But at the time of conception, she was minor, so it becomes a case of POSCO. If you have time, then you can inform before cesarean section. If it is immediate required, then you can go with cesarean section, and before patient leaves your premises, you have to inform police.
Okay.
So we are back to Nishi ma'am again. Over to you, Nishi ma'am.
17-year-old girl is brought by her mother saying that she is 6 weeks pregnant and they want to terminate the pregnancy. So the doctor has examined and tells that you have to be informed to the police because it is an offense. But the patient and mother refuse for the same and leave the place without taking any treatment further. What will you do? I have one more question, sir. If it is a male doctor, what will you do?
So in this situation, even if you have treated that very patient further or not, it doesn't makes any difference. But once you came to know that she is minor, she is 6 weeks pregnancy, it becomes a case of POSCO. You have to inform police. So even if patient has left without taking further treatment, then also you have to inform police.
So sir,
yes,
Raju.
Yes.
Can if a male doctor, can he examine?
Yes. So in this, if it is an acute emergency, whosoever is available can examine and can treat that very patient in that very given situation. But if female doctor is available, then preferably, not compulsory, not mandatory, preferably this should be examined by female doctor and she should be treated by female doctor. But if it is an emergency, no need to wait for female doctor to come and to examine and to treat. Any doctor can treat that very patient.
Okay, thank you, sir.
Muraleedharan sir, over to you, please.
Yes, sir. My question is, having learned all those things now, what is the role of a doctor when a victim is brought to him? And what is expected under POSCO Act about reporting of an offense?
Yes.
And other.
So whenever this type of patient is brought to us, when she is minor,
default speaker has
and
changed
any history of sexual assault, then naturally we have to examine that very point. Before that, we have to start with consent, because without consent, we cannot examine.
Okay.
And if she is more than 12 years, even she is minor, less than 18, then also she can give consent for examination. But she can give consent for examination only if any intervention is required. Say, for example, if she is brought and she is bleeding and some stitches are required, then you have to go for sedation or anesthesia. In this situation, she cannot give consent. So consent of guardian is required in this situation. Otherwise, for mere examination, she can give consent. So once consent is given, then we have to go with history. History, whether this incident happens only once or repeatedly she had been victim for this type of activity. One more thing, after this incidents happen, has she taken bath? Has she changed clothes? Because these small things are very important at the time of arriving at the opinion. So with history, then examination and collection of evidences. So examination part, vulval part, vagina, perineum, breast, and on any other body part, if there is an injury mark, then we have to note in our case paper, and we have to collect evidences also. Say, for example, underwear with blood stain or cement stain or any other stain. And these are the evidences as far as our opinion is to be proved in court of law. At the same time, we have to treat that very patient, and we have to offer prophylaxis for STD also, HIV also, because we never know that person accused could be HIV positive and she may succumb with HIV in future. So not to end up into this type of situation in future, we have to offer prophylaxis for HIV also. So consent, history, examination, collection of evidence, and then after we have to form opinion whether she is victim of sexual assault, and if it is yes, we have to inform police. And when we inform police and in court of law, at the time of deciding this case, we may be called as an expert witness and we have to justify our opinion in court of law with our case paper, etc. One more question you ask in case of failure to report. So under section 19 of POSCO Act, being a responsible citizen of India, we are under obligation to inform police when any minor is brought to us with sexual assault if she is victim. And if we fail, then there is a provision in section 21 of POSCO Act, and there is a provision of imprisonment for 6 months. And if one is head of the institution, then provision of 1 year of imprisonment and fine or both. So we cannot afford that. So in this type of cases, we are under obligation to inform police or member of CWC. You have mentioned how to inform. Inform with acknowledgement. Because if you have not taken acknowledgement, police may go hostile. You never inform. You didn't inform. So always inform with acknowledgement. Many a time police is not ready to give acknowledgement also. If you have sent your person with 2 copies and police station officer is not ready to sign the document. So in this situation, you can send it by registered post, by mail. You can have a phone call to number 100. Number 100 call is recorded call. But in this situation, when you inform anybody, then identify the person whom you are giving information, name of that very police station officer, and they are given with buckle number. So note buckle number, date and time is very much important. If you have facility to record in your own mobile, you can send this information from your mobile also. And in mobile, you can inform police with identification of the person whom you are informing. If lower police station officer is not complying, then you can inform higher officer also. Or you can inform member of CWC, that is Child Welfare Committee. And if you inform Child Welfare Committee, then member of that Child Welfare Committee will be in action and he will manage to approach to police station and you are out of picture. Because our role is merely information. We are not complainant. Either we have to inform police or we have to inform member of CWC.
Okay, thank you, sir. Thank you.
Manjunath sir, over to you, please.
Madam, thank you. Thank you. Thank you for letting me in. Madam, sir, I was asking you last time that how to examine a patient in case, do we have to, sir, do you think that we need a forensic expert to examine while we conduct an examination, or it will be a different kind of it?
No, as such, as per law, any registered medical practitioner can examine. Even at primary health center, patient is brought and mere MBBS doctor is on duty, he can also examine patient. It is not necessary that gynecologist or forensic medicine person should only examine. But there is a protocol, how to examine, how to collect evidences, how to form opinion, and there is prescribed form also on part of, it is available on web also. And there is a kit as far as examination part is concerned. Say, for example, if you have to collect pubic hair, so there is a comb also in that very kit. There is a small scissor is also there in that very kit. So with this kit, we can proceed further accordingly as far as examination part is concerned and collection of evidences part is concerned.
Sir, it will be most this one thankful. I will be most thankful to you, sir, if you could explain me the methods of examination of a patient when a patient comes with a sexual assault. So what are the things that we need to do? And
so
how
I mentioned little prior also. First, we have to take consent, then we have to take history, and then we have to examine patient, particularly for any injury mark or sign of any penetration or sign of any sexual assault, because ultimately we have to form opinion, and we can form opinion from whichever sign we can collect during our examination part. So any injury mark on breast, on face, on perineum, vulva, vagina. So if we find any injury mark, and if we can come to conclusion that it could be a part of sexual assault or penetrative form of sexual assault, then we can form opinion with finding of our examination.
Sir, let us say that she is child. She is very young and she is not able to decide on, and she is very much reluctant to get examined. So can we sedate in such situation?
Yes. So in POSCO Act, there is a provision. We can go with sedation, but in this, patient cannot give consent because she is minor. So for sedation or general anesthesia or whichever, we have to take consent from guardian. Guardian means person who guards the patient is guardian. Not necessarily that he or she should be a mother or father. Because say for example, from school, if school teacher has brought that child to you, school teacher is guardian, and school teacher can also sign as a guardian in this situation. And you can very well go with sedation or anesthesia for examination and for further treatment also.
Sir, is it that whoever is on duty should be examined? Suppose if I'm on duty, if I'm in a OT, suppose if such a POSCO, related to POSCO Act case comes, so is it whose duty to examine? Is it that I have to come from the OT and examine the patient, or any other doctor?
If you are busy with some other emergency, naturally you cannot leave that emergency also. Because in eye of law, once you start treating any patient, it becomes a contract between that patient and yourself. You are offering your expert services, patient pays for that or patient promises to pay for that. So when you have started treatment with some other case and you are busy with treatment, if it is an emergency, you cannot leave that patient and you come to examine that case which is brought to you related to POXO. In this situation, person who has brought that patient can take decision whether she is in a position to wait or she can take that patient to another person.
Okay. Sir, within what span of time, sir, we have to examine the patient? Let us say that I'm there and even others are busy. Let us say a case comes. So which is the time span within which...
Yes, by law, no time span is decided, but it is only expected on part of law. At earliest possible, we should examine patient. If we are busy with our other emergency and if we can prove in court of law with our documentation, our records, then we are pardoned that we were busy with some other emergency.
Sir, thank you. Thank you very much, sir. Thank you.
Over to you, Maneesha, ma'am. Dr. Maneesha.
Madam, sir, can I, doctor refused to examine a victim of sexual assault who came to the hospital for treatment, citing that it's a mercy case and require a police requisition or magistrate order.
So, whenever this type of patient is brought to us in any clinical establishment, whether it is government, whether it is medical college, whether it is private, whether it is trust hospital, we are under obligation to examine and to treat that very patient in given situation. This is provision of POXO Act. And we cannot refuse any patient for examination in that very situation.
Okay, thank you, sir.
And hello. Mention, you do not need any police requisition. You do not need any magistrate order. When patient is brought to you by a relative or school teacher, say for example from school, no requisition from police or magistrate is required. You have to straightway examine patient and you have to deal with the case accordingly.
Thank you, sir. Thank you.
Yes, next.
Hello. Hello.
Yes.
Hello. Able to hear me, sir?
Yes. Welcome.
I am Dr. Samartharam.
Yes. Welcome, sir.
I would like to share an interesting case of POXO. The girl is less than 18 years. Boy is around 21 years. Both the families, girl side and boy side, they want to get married done. And married is delayed because she's this lady was taken to a gynecologist. She said it's a POXO case. She reported the case to the police station. Police came and made an FIR. Once they made an FIR, the case has gone to the court. And both the parties, for boys side and girl side, they're not happy. They're going on crying. Ultimately, she's pregnant. She booked with me for antenatal checkup, and I was going on examining. And meanwhile, the case was running in the court for months together. Meanwhile, this girl delivered with me, and I didn't have any problem, not a problem at all. And both the parties went home, and the case was going on running. And she crossed more than 18. The boy is also aged. Then finally, she became pregnant second time, and second time also she delivered with me. Then she had 2 kids, and the case of POXO was running in the court. Finally, our lawyer, the girl side lawyer, asked the judge, "Sir, the girl is having 2 kids. Sir, do you want to continue this case?" Immediately, the judge just struck down the case and the case was closed.
So it's fine, case is closed, but under POXO Act, marital status doesn't matter, age matters. So if she is minor, even if she is married, even she is having child or children, then also being a responsible person, we have to inform police. We are not complainant. We are only informer. We have to simply inform police that patient so and so, aged so and so, residing at had been to me, and she was found to be 6 weeks pregnant. That's why we have to simply inform. What police has to do, that is up to them. But in few of the cases, just you mentioned like that case, in one of the cases, even Supreme Court also has mentioned that if they are happily enjoying their married life, and if they have no problem in their very family, and if they are minor, both, husband and wife both, and if it has come to doctor and doctor came to know she is pregnant, she is minor, so under POXO Act, as such, doctor is duty bound. It is mandatory for doctor to inform police. But if marriage life is more than 1 year, then court has mentioned, if doctor has not reported to the police, then doctor should not be held responsible for that. But we are waiting for that judgment, and we will have to study exact word to word of that very judgment. So if it is so, then in this type of situation, if we have not informed police, then we can be pardoned. But as on today, if we go with true spirit of act and word to word interpretation of act, if patient is less than 18, irrespective of our marital status, we have to inform police.
That's one thing. One more interesting, one more tricky issue. Suppose the mother was, girl was brought here, less than 18, she became pregnant, and I want to report to the police. The parent doesn't want to report to the police. Then I have informed the police. Will there be, suppose if there are attacks on me by the parent party, what can I do?
So as far as willingness on part of parents or any person who has brought to the patient to us doesn't matter in this situation, because we have to inform police, even if they are not ready to inform police. One thing, as far as assault on part of parents are concerned, you can file complaint against them also in police station for assault, and it will be taken seriously in eye of law, because whenever you inform police, you are helping law to come to conclusion whether she is victim of sexual assault, and you are helping court and law to come to a conclusion and to punish a person who is accused. So whenever you are helping law and one attacks, then you are always taken into consideration by court also. So if you file complaint against those people, then they will be taken seriously.
Patel sir, one more question. Yes. Suppose a lady has come for the second time delivery, and on taking history, pregnancy and antenatal care, and on taking history, we found that the first pregnancy and delivery occurred when she was as far as a POXO Act.
We have to inform police. We have to inform police, because once we came to know when she was minor, she conceived, it becomes a case of POXO.
She came for second delivery, no, sir.
Even second, third,
second delivery she came. And
Patel, sir. If, for example, the third or fourth delivery.
Why should we bother about first delivery, sir?
Patel, sir, I need the questions to be finished first, which are structured. Because three more remain, and then you can take general questions. We have one lecture also.
Yes, Latika. Welcome.
Yes. This is similar question. 17-year-old girl visits a private hospital with history of sexual assault, and the doctor asks her to go to a government hospital as it is a MLC case and has to be examined by a government doctor. Now, the question is it mandatory that a victim of sexual assault has to be examined at government hospitals? Second, is it necessary for a female doctor only to examine sexual violence victims?
So, as such, it is discussed prior also. It is not at all necessary that this type of patient should be examined at government hospital only. Whenever this type of patients are brought to any clinical establishment, whether it is private, whether it is a trust hospital, whether it is medical college hospital or district hospital, a patient has to be examined, and she should be treated accordingly. And it is not at all necessary that female doctor only can examine. If female doctor is available nearby, it is preferable to be examined by female doctor. But if female doctor is not available, and if she is an emergency, say for example, she is bleeding, and in this situation, any registered medical practitioner can examine that very person and can treat that very patient accordingly. Yes,
Thank you,
next.
sir.
Only one question, sir. Suppose such patients come to us, and do I have the right to refer the case and refuse to see the case?
Of course, you can refer patient, but if it is an emergency, then you have to stabilize patient. And in this situation also, you will have to inform police that it was case of she was minor,
POSCO.
it was case of POSCO, but I am working at place with limited resources, and it is difficult to manage that very case at my place. I have given primary treatment or emergency treatment, and I have referred patient to higher center. But you will have to inform police, and once you inform police, it shows your intention to help law to come to conclusion. Yes, next, Lola madam.
Yes, sir. Now here, this is actually happening many a time in our OP. A 17-year-old girl is in a relationship with a boyfriend. And when she failed to get her periods on the due date, she became anxious. And she was worried that she's pregnant. And then she tells the gynaec that she has had sexual contact with her boyfriend. And she's worried about her conservative parents, how they would react, whether she could continue her studies and so on and so on. So now here again, whether we should inform the police, whether to inform the girl's parents against her wishes, that is one major question, and whether to counsel the girl about safe sex and advice about pregnancy and antenatal care.
So as far as information to the police is concerned, yes. And whether to inform girl's parents against her wishes, because here in this case she is 17 years. When she is more than 12 years, she is able to give consent for examination, and when she is able to give consent for examination in eye of law, she can take decision whether her parents are to be informed or not. And if she is not willing to inform her parents, we cannot inform her parents. And as far as this sex education, etc. is concerned, we have already discussed this. Yes, next.
One question I would like to ask you. The girl has come, is a young girl in adolescent age. She is pregnant. She will say, I am 19 years old. And should we ask for an Aadhaar card or any document from everybody?
Yes, yes. So
in what way, suppose she says, I am 19 years old, in what way we can't make a forensic examination for every adolescent girl, no?
So whenever you are in a little doubt related to her age, because in court of law, you are responsible to determine age. So to determine age is on doctor's shoulder. So we have to examine her clinically, dental examination, we can advise radiological examination, we can ask for forensic opinion also through police. You can inform police that way. I am not sure about her age. She seems to be minor, and please help me to arriving to my decision whether she is minor or not. If you inform this way in police, it shows your consent that you are going to help police. So you are out of problem. If you do not inform, or if you believe, because many times patient will go with fake information, such though she is 17 or less than 18, she will tell I am 19. So at that point of time, you can ask for any ID proof also. Aadhaar card, driving license, school leaving certificate, election card, you can ask for any ID proof. But many a time, they may produce fake proof also.
Yes.
Because in one of the cases, it happened in state of Tamil Nadu only. They produce Aadhaar card, but it was fake. So whenever you attach this type of document with case paper, have this document attested by that very person. So even if she has produced fake certificate, you could be out of problem. And one more thing, now it is possible to verify Aadhaar card on online also. So if you have time and if you can verify, it's fine. Otherwise, get this certificate attested, and at your leisure, you can verify. And if you come to know that though she was minor and she has come up with fake documentation, it becomes a case of fabrication of evidence, and you can inform police for that also.
We will be running a forensic clinic than the antenatal clinic, sir.
No, but whenever you are facing this type of cases, you are under obligation to manage patient accordingly, because under POSCO section 19, you are under obligation to inform police, and if you fail, that under section 21, there is a provision of punishment for 6 months, and we cannot afford that.
If you exhibit all these things in front of your antenatal clinic, no, do you think any patient will come to us?
Yes, how many this type of cases we face in our day-to-day OPD? Very rare. No?
One more thing, sir. Suppose it is 15 years, 16 years, you can make out. If it is 17 years,
yes,
17 years, 19 years, you can't make out.
But that is why we can inform police. I am not sure, but it seems to be minor. Please help or please guide. That way you have to write to come to conclusion, and you can request through police to subject that very patient for opinion from forensic medicine department.
One more question, sir. Suppose if she says 18, 19 years, maybe 17, I don't know. I believe that she is 19 years old, and I continue my antenatal checkup. Is there any wrong in that?
Then you can continue with antenatal checkup, no issue. But if she turns out to be minor, then you have to inform police. Simple. Because many times patient is willing to continue pregnancy. It is not necessary that patient will be willing to terminate pregnancy. Many times she is married. She has come for antenatal checkup only. She is willing to continue pregnancy. Of course, you have to treat. We have to offer all antenatal checkup with all necessary investigation and treatment. But in this situation also, we will have to inform police.
Usually, the question is if we are in such a case, 18 years patient, 19, I believe it, and continuing pregnancy, nobody will try to bring her date of birth card and go to court. No, usually such things go without knowledge, and only when police or somebody complains, only these things will come into light and will be in
once
problem.
You have not informed, and say for example, case is filed, the family of that very girl has filed case against that boy, then naturally during investigation she will give history that I had been to Dr. Samarthram. Then police will come to Dr. Samarthram.
Yes.
Why didn't inform? And you will be in trouble. So not to end up into this type of problem, we never know whether this case will go very smoothly or they will go with litigation against that very boy. So not to end up into any problem in future on our side, it is always better to inform.
Sir, what is the relevance of this law in your regular day-to-day practice and the ethical values of this law in your personal opinion?
As such, this act was enacted to check sexual offences against children. Whether it is sexual harassment, whether it is sexual assault, whether it is penetrative form, whether it is penetrative form, or whether it is aggravated form, but he addressed to this offences, and for special provision of trial of these cases in court and investigating part, and they form CWC also. That is 1 point clinic. One patient comes to that 1 point clinic. They will take care of everything. They will inform police, they will examine patient, they will form opinion, they will treat that very patient. Even psychological boost will also be given to the patient, because many times this type of patient are vulnerable for psychiatric problem also, depression or any other issue. So in CWC, there is a provision for psychiatric backup also. So as such, aim of this act is very good. But as far as age limit is concerned, 18 years. And nowadays, before 18 years, it is all possible that they may enter into sexual
activity.
Life.
That's all.
Yes. Yes, Madam Parvati, your turn.
I would like to, sir, one question I would like to ask you. After passing this law in the parliament, are there any reduction in the crime on the children? Your opinion?
Exactly, I do not have statistic, but with any enactment of any this type of act or law, naturally it will affect. And the child abuse is, I cannot say they are all prevented, but once any accused is found guilty, and if it is proved in court of law, there are so many judgments. They are punished with lifetime imprisonment or 10 years imprisonment or 5 years imprisonment as per case. So there are so many judgments in court related to POCSO. Yes, Madam Parvati.
A 17-year-old had eloped with her boyfriend and became pregnant with 16 weeks of gestation and has requested for MT. She is not willing to reveal her boyfriend name and requesting not to inform the police. Her father is refusing to give consent for MT. So what should the doctor do? Whose consent we should take?
So in this situation, even if she is not willing to inform police, we have to inform police. Because willingness on part of patient or relative doesn't matter, we have to inform police. Second part, her father is refusing to give consent for MTB. As far as MTB part is concerned, she is less than 18, she cannot give consent. So any other guardian who is major and mentally sound can give consent. It need not consent to be taken from father or mother only. So any person can, in big institution, head of the unit, head of the department, head of the institution can also give consent, being a guardian. Or if you inform CWC, then many member of CWC can also give consent for termination of pregnancy.
So once informed to the CWC, the father consented for MT. MTP was done and now the father is insisting for products of conception to be sent for further investigation. But the girl says that she doesn't want to implicate boyfriend with DNA analysis. So what should the doctor do?
So in this situation, when she is more than 12 years, I mentioned prior that she can give consent for examination. And she can take decision also whether product of conception is to be sent to police for further investigation or not. But at the same time, we will explain her importance of collection of evidence, importance of this product of conception to be examined for DNA testing. And even if she refuses, then we will record in our case paper that she has refused to send this product of conception to police for further investigation, and we will have signature of that very patient because she can take decision. But at the same time, once we have informed police, now whole case is in hand of police. Then police will manage to explain her, to convince her for product of conception to be sent for further investigation. Once you inform police, your job is over.
Sir, one more doubt. I recently had a case. Sir, can this MTP in which the DNA analysis is to be done, can be done it in a private setup or it should be always done in a government setup?
We can do MTP in private setup also if our center is registered under MTP Act and we are qualified person.
So the DNA analysis sample, so we will have to hand over?
Even if you are dealing the case in your private, once you have informed police, you will inform police that you are going to terminate pregnancy of that very patient on at. Please send your representative to collect product of conception, which I am going to preserve in normal saline. If police doesn't turn up, your job is over once you have informed. You can inform again also that if you do not collect this product of conception within 72 hours and if you do not send it for further investigation, after 72 hours, it won't be available for DNA testing because we have preserved in normal saline. And after 72 hours, it is all likely that the sample may go Paris and DNA testing will not be that effective as far as investigation is concerned after 72 hours. But once we have informed police and police has not turned up, it is not our duty or we are not at all at fault. We have to inform simply.
Sir, does it stand in the court of law that if we do it in the private, because they may say that we had done something, we have manipulated the evidence or something?
No. We have collected that very evidence and we are ready to give that very evidence to police. So when our intention is bona fide and if we can prove it by our record, nothing to worry. We can terminate pregnancy in our hospital, private hospital also.
Okay, fine. Thank you, sir.
Sir, one question. Suppose if she's above 12, she can give consent, no? If
Yes.
she's below 12, there is a disparity. If she wants to continue pregnancy,
No.
guardian
If she is less than 12, she cannot give consent for examination also. In this situation, consent for examination also, we have to go with consent from guardian.
Suppose she is not cooperating, then this may be difficult, no? If she is.
So when she is not cooperative for examination,
And
say, for
police.
example, if she is more than 12, and if she has given consent but she is not cooperating, then it is not at all necessary to continue with examination. We can mention in our case paper, patient is not cooperating and patient is not willing to for examination, and we can differ with examination. It is not
Below 12? Below 12? Below 12? If she's not
below
cooperating?
12, we have to go with consent from guardian only.
And then somehow
And
do it.
if guardian is ready to be examined under sedation, then we can go with examination under sedation.
Okay, sir. Thank you. Thank you.
So hope I have justified my role as a moderator.
Thank you, sir.
Very nice.
Thank you.
Thank you, sir.
And now my
Thank you,
humble
respected
request.
panelists.
Yes.
Sir, if you want to make a vote appeal before
Yes. So
introduce
before
the
you
speakers.
switch over to second lecture, it is my humble appeal to all of you to consider my candidature for post of President FOXI this year. Election would be from 1st August to 10 August. Consider my seniority, sincerity, dedication, and easily availability to any FOXian friends in any medical legal crisis. And at the same time, I would like to appeal for Dr. Asha Jain also. She is contesting for post of chairperson rather, for Food, Drug and Medical Surgical Equipment Committee, and her election would be from 16 August to 25th of August. So please consider candidature for both of us, and please keep your blessings. Thank you.
Yes,
Thank
sir. All our best wishes.
Thank
Sir.
you
Wish
so
you best
much.
of luck, sir. God bless you.
Thank you.
Dr. Kalpana, are you there? Dr. Kalpana?
Yes, ma'am, I'm there.
Yeah. Please introduce our chairpersons.
Yeah. I didn't get the name, madam.
Yes.
Madam's name I'm not getting.
Dr. Gracie Thomas.
Yeah. Dr. Gracie Thomas is gynecologist. She did her MBBS from St. John Medical College, Bangalore, and DGO from Trinity College, University. She is a gynecologist at St. Martha's Hospital, Kochi, from 1977, and gynecologist at Bangalore City Hospital and Sunrise Hospital, Kochi, and now at Grace Clinic, Kochi. She's a member of Indian Medical Association, and she has many awards in her name. Dr. M. Venugopal, he's a very good teacher. I am one of his students, ma'am. He's an IVF specialist and also laparoscopic surgeon. He did his DNB from BJ Medical College, Pune, and also MD obstetric and gynecologist from BJ Medical College, Pune. And he's at present working in Thrissur, madam. And Dr. Samath Ram, he's a director and head chef department of obstetric and gynecology, Sandhyaram Hospital, Palakkad. He is a winner of prestigious senior category FOXi Korean Award and 3-time winner of Dr. C.S. Don Prize and FOXi Figo Award. So many big list of publication is there, and awards are also there. His special interest is in PPH, preeclampsia, and programmed labor guided by 4-water mixed floater density. Welcome, dear doctors.
Thank you. Thank you very much, ma'am.
So, Dr. Samarthwa Ram was panelist or chairperson, because though he is chairperson, he asked so many questions at the time of panel. Of course, welcome, Samarth Ram. You are good friend.
Thank you, sir. Thank you. Nice of you, sir.
Yes. Welcome.
Over to the chairpersons to please introduce Elizabeth, ma'am.
Hello. Good evening.
Welcome, madam. Welcome.
Yeah, she is senior consultant HOD Apollo Adlex Hospital, Angamaly, Kochi, and she is very close to us, madam. And she's very vibrant and active in all KFOG activities, madam. And she has a list of
Kalpana, Dr. Kalpana, you're not supposed to do it. Requesting chairpersons to do this.
Gracie, madam. Gracie, madam,
Okay.
you can introduce.
Thank you. Thank you, Dr. Patel and Dr. Asha, for inviting me as the chairperson, and all the best for your post and the election. And thank you very much. And Dr. Elizabeth Jacob is a very well-known speaker and a very smart lady from Kochi. And now she is head of the department in Apollo Adolescents Hospital. She always gives good lectures. She has a lot of awards. I don't want to waste the time. It's already late. Anyway, all the best. And she's going to talk on AUB in adolescence. And I think it is a very interesting topic. And I wish all the best for Elizabeth. And it is a very difficult topic and very difficult problem for all the gynecologists when all these adolescents come with AUB. I'm sure Elizabeth is going to give us some new points in this regard. Okay, over to you, Dr. Elizabeth. Hi.
Hello, ma'am. Thank you for those kind words of introduction. I hope it's full screen, and I hope I'm audible.
It is full screen.
Yes, we can see you, and we can see the screen also.
A very warm late evening to all of you, and heartfelt thanks to M.C.Patel sir and Asha madam for this invitation, and the very best for the elections that are due in August. Actually, after a very elaborate and I think exhaustive reverse panel, I think we truly enjoyed hearing you, Sir M.C.Patel sir. As always, a lot of medical legal points you elaborated. I think I fall short on my presentation, but I'll try to do as much justice as possible to do. It's like batting at the 9th position after the sixer and fourth have been already played by M.C.Patel sir. But still, I'll try to do justice to the talk that has been awarded to me. Asha Jain ma'am, thanks for the opportunity and thanks for your lovely words. Kalpana ma'am too, thank you. And Grace ma'am, as always, she's a mother figure to us because we have been part of Cochin Society before. So thank you ma'am for those wonderful words of introduction. As far as adolescent AUB is concerned, I think there are lots of whats and there are lots of whatnots, and we'll try to go through that. And why we need to discuss it is because it is one of the commonest gynecological disorders in adolescents, affecting almost 40% of adolescents and affecting their quality of life in multitudes of ways. So it's extremely important as gynecologists that we know about adolescent AUB and how to treat them with empathy and being non-judgmental. The lecture today will be based on mainly the ACOG committee opinion, the update 2024 by Nirupama and the FIGO guidelines, and of course, the other literature updates. The normal menstrual cycle in adolescent, we all know, I don't want to be going through it as we are already running short of time, but we know predominantly that in the first 1 or 2 years, the cycles are predominantly anovulatory. And this anovulatory cycles is the reason for the estrogen breakthrough bleeding that occurs till estrogen repair actually takes place. The endometrium lacks the stability of the effect of progesterone, and hence we have the estrogen withdrawal or the estrogen breakthrough bleeding. What we need to understand is that about 60 to 80% of adolescents reach a cycle similar to adults by the 3rd year after menarche, and this reversal to the ovulatory cycles depend on when they actually had their menarche. If they had their menarche in an earlier phase, less than 12 years, within 1 year they have ovulatory cycles. And if it's more than 13 years, it takes them about 4 to 5 years to actually get an ovulatory cycle. We all know the multitude of terminologies that we used before. And we all know that this wave of change happened with FIGO introducing the palm coin system, which was finally revised in 2018. And this is what we follow even for the adolescent age group. This standardized the validated terminology, but we always need to remember that the AUB system or the palm coin AUB system of the FIGO does not include pregnancy-related causes. The acute, chronic, heavy menstrual bleeding and intermenstrual bleeding terminologies are all well known to us. Acute is whenever there is need for immediate intervention to prevent further blood loss, and chronic is when there is a problem with the duration, volume, frequency, and regularity for at least the preceding 6 months. So basically, these were the parameters that were included. This is all known. Since we are lacking time, I'm just rushing through it. What we need to remember is that in this change of system that happened with the FIGO system, there were two parameters which are relevant for the adolescent. One is when they talked about regularity, as far as the adolescent age group and the perimenopausal age group was concerned, the variation was, the regularity duration was increased to 8 to 10 days from 7 to 9 days that was normally constituted. Also, the volume or the amount of blood loss is the only parameter in this 4 parameters that is based on the patient's effect on her quality of life being affected with the amount of blood flow. So the patient decides the volume of blood flow to be severe enough to call it a heavy menstrual bleeding. But to simplify the definition in adolescents, the 2023 ESHRE guidelines or the ASRM guidelines which came from PCOS simplified it to us in this way that the first 1 year, it is very common to have irregular periods and you do not need to classify it as AUB, as irregular cycles. Between 1 to 3 years of post-menarche, between 21 to 45 days is the cycle duration. 3 years post-menarche, it's 21 to 35 days or less than 8 cycles per year. And 1 year post-menarche, if you do not have a cycle for more than 90 days, you need to classify it as a irregular or abnormal uterine bleeding. We all know the palm coin system, but what we need to know is that in the adolescent, it is the coin that predominates, and of which the AUBO or the anovulatory, which is the commonest, and second comes the AUBC, which is the bleeding dysfunction, which accounts for about 20% of adolescent AUBs that present to us. This is the table which shows the different causes as far as AUB in adolescent age group is concerned. I do not want to go into the detail, but just to hurry up with the important parameters, the first and most important, like we said, is the anovulatory causes. For that, in addition to the dysfunction of the hypothalamo-pituitary ovarian axis or the immaturity of the hypothalamo-pituitary ovarian axis, we need to consider PCOS, thyroid dysfunction, hyperprolactinemia, hypothalamic dysfunction, tumors, hypercortisolism, and pituitary disease. Depending on the symptom, you can see the symptoms that have been elucidated. You need to work up on these conditions. Also, you need to think about medications, especially hormonal contraception. Even with, as we were discussing the POSCO case, we know that many of the young adolescents are sexually active and they might be taking oral hormonal contraceptives or even the commonly available I-pill. Use of androgens, antipsychotics, and antidepressants which affect the HPO axis, corticosteroids, then chronic diseases, and also let's never forget the sexually transmitted or STI diseases. The other main chunk that we discussed is the coagulopathies or the bleeding disorders. So if they have a heavy menstrual bleeding since menarche, that is those patients in whom you should definitely think about the possibility of a bleeding disorder. Any one of the following of postpartum hemorrhage, surgery-related bleeding or bleeding associated with the dental work, in which the only last two account for the adolescent age group. Any two in terms of bruising, epistaxis, frequent gum bleeding, or family history. So this history should alert you to think about the possibility of bleeding disorders, commonly the thrombocytopenia, von Willebrand disease, and also medications. Structural anomalies are extremely rare, less than 1.6% accounting for the adolescent AUBs. But you need to always think about the IUDs. The intrauterine devices are also being used by some of the adolescent age group and may result in irregular bleeding. Always look for the other sites. Just keep in mind the ovarian, the cervix, the vagina, vulva, trauma, sexual abuse, and so on and so forth before you actually conclude that the bleeding is from the uterine cavity. There are different diseases, bleeding disorders, which can account for the adolescent AUB, but the most commonest is the von Willebrand disease and the thrombocytopenia, the idiopathic thrombocytopenia. As far as the bleeding disorders causing AUB is concerned, whenever heavy menstrual bleeding occurs at menarche and in the adolescent, it could be the first sentinel marker for you to diagnose an underlying bleeding disorder. So since menarche, if she has a heavy menstrual bleeding, keep that in mind. The other important aspects as far as the bleeding disorders are concerned is that in addition to the irregular prolonged cycles, they may present with recurrent episodes of corpus luteal hemorrhage, which can actually rupture and present with or without hemoperitoneum. So this presentation should also be kept in mind in case of bleeding disorders in the adolescent age group. Now, coming to the evaluation in adolescent age, you need to look at the history. Definitely the menstrual history, the sexual, medical, and family history. You can use tools to evaluate them because they are young girls. They may not be able to actually tell you in detail. So either the menstrual calendars, there are mobile apps that are available now, the pictorial blood assessment chart, the long time what we have been taught, and questionnaires can be used to elicit a detailed history about the amount of blood loss. But we should never forget the role of the caregiver. Just like a 12-year-old, 13-year-old comes, she will not be able to explain to us the confidentiality that we need to maintain, especially when we take the sexual history and being non-judgmental in this young adolescent age group. In the history, definitely you need to take a detailed menstrual history, the age of menarche, the menstrual pattern. Was there anything else that preceded the menstrual pattern? And did it start from the beginning? Like we already said, if the HMB starts since menarche, it is a pointer towards a bleeding disorder. Sexual history, definitely you need to look at the sexually transmitted disorders, look at oral contraceptives that may be used, the past medical history in which the chronic medical illnesses that could contribute to this. The other system should be reviewed in terms of hyperprolactinemia, dysmenorrhea, galacturia, joint hypermobility. All those will be pointers towards the system involvement. Family history is extremely relevant in case of bleeding disorders. And social history in the form of social substance abuses and also school absences and how much this actually has affected her day-to-day education or her day-to-day social life should also be elicited. But this chart from the up-to-date, actually, I found it extremely useful when the AUB in the adolescent can be actually, the history can be elicited based on the type of bleeding pattern that she presents with. If it's just an irregular bleeding, which is unpredictable in timing and volume, most common cause could be anovulation, which could be PCOS, and less commonly because of the hypothyroidism or hyperprolactinemia. When it is regular cycles with increased flow, the commonest thing that should strike you is the possibility of bleeding disorders. It could also be related to some of the medications that she is using. If she has a regular menses with an intermenstrual bleeding, always keep in mind the possibility of sexually transmitted infections as well as hormonal contraception or intrauterine devices. If it's extrauterine causes of intermittent bleeding, think about perineal trauma, cervical polyps or cervical ectropions and medications. So by the history, by the pattern of the menstrual bleeding in the adolescent, you can get very good clues as far as your diagnosis is concerned. I already explained about the tools. So you can use a simple menstrual calendar record. You can ask her questions depending on how often do you change your pads? How many pads do you use in a single menstrual period? Do you need to change at night? And are you anemic? So if it's a normal volume, usually it changes at an interval of more than 3 hours with less than 21 pads in a cycle, and seldom they need to change at night and do not have clots more than 1 inch and are not anemic. So these are parameters these are questions that can actually help you to decide the amount of bleeding in an adolescent age group. The pictorial assessment, we all know anything more than 100 is considered to be heavy menstrual bleeding. Always remember to plot the palm coin diagnostic matrix, even in a case of an adolescent AUB, which will help you to pinpoint the cause for the same. The ACOG committee opinion in 2019 gives a beautiful screening tool for actually assessing the bleeding disorders in these young adolescent girls by asking them pointed questions. So whenever you have a duration of menses more than 7 days and she has a history of flooding, with a history of anemia, with a family history of diagnosed bleeding disorder, and a history of excessive bleeding with tooth extract or any of the surgeries, those are pointers that you need to think about a bleeding disorder. So all these diagnostic tools and your history should be able to clinch a diagnosis as far as the adolescent AUB is concerned. Having done that, then you move into the examination. The first and the foremost is to see that is she hemodynamically stable. So tachycardia, hypotension, orthostasis are extremely important. Then look at parameters which may give you a clue to an endocrine pathology. Look at the hirsutism, the acne, the acanthosis, which was already described, signs of virilization, the thyroid enlargement, which you could see, any pointers towards a Turner syndrome. Normally, you do not do a speculum or a pervaginal examination unless you are suspecting any sexual injury or any sexual abuse or a pregnancy. The basic investigations as far as an adolescent AUB is concerned is getting a pregnancy test done in confidentiality and privacy. We need to keep that at the back of our mind in all our young adolescent girls. A complete hemogram, a platelet, and a serum ferritin to assess the amount of blood loss, and also to know her basic hemogram, a TSH, a PT, APTT, which can be helpful in giving you pointers towards bleeding disorders. If galactoria presents, for a prolactin level, if sexually active, screen for STIs, and work up for hirsutism if it is grossly obviously present. As was explained in the hirsutism talk, testosterone over 150, think about ruling out ovarian and adrenal tumors. 17 OHP, in cases where there is severe virilization, you need to think about the non-classical congenital adrenal hyperplasia. When it is very much elevated, DHEAS, you need to think about the adrenal tumors. In other conditions, you just need to know the basic investigations before you actually go into the management. Ultrasound is not routinely indicated. As we already discussed it with PCOS, till 8 years post-menarche, ultrasound should not be used to diagnose PCOS. So unless she is sexually active, only a transabdominal ultrasound should be done. In those conditions who do not respond to the initial treatment, in whom you suspect a pregnancy or a structural defect is suspected. Other than that, you do not need a routine ultrasound in these young girls. What about the management goals? The main management goal is hemodynamic stability to be confirmed, correct the anemia, return the young girl to an almost a normal menstrual pattern, prevent recurrences for her, and prevent long-term consequences of anovulation, such as the fertility issues and endometrial hyperplasia. So basically, a clinical stability, overall equity, a suspected etiology, and an underlying medical problem. These are the things that your main target should be when you're managing a young girl with abnormal uterine bleeding. As we all would agree that medical management is the first line and the treatment of choice. Admission is indicated only when the patient is hemodynamically unstable, when there is severe anemia to the tune of less than 7 grams and there is a need for blood transfusion, and she continues to bleed despite 72 hours of instituting your medical management, and you suspect that there might be a need for a surgical treatment. What are the critical interventions? That is when you need to actually admit the patient, you might need to give her fluid resuscitation, blood transfusion as and when it is indicated, blood product transfusion in cases of bleeding disorders in consultation with the hematologist, and an urgent control of bleeding. So these are the extremely important parameters that we need to look into. Acute control of bleeding, I think all of us are very well versed. We all use the combined oral contraceptive pills as the first line in order to control heavy menstrual bleeding. Monophasic pills with ethinyl estradiol of 30 to 50 microgram is the first choice. You can give it every 6 to 8 hourly till the cessation of bleeding, which usually happens between 24 to 48 hours. And then you can proceed on to tapering the dose and continuing it till actually the patient is under control of the bleeding. In those very patients in whom estrogen is contraindicated, you can consider the progesterone. Tranexamic acid as a first line for acute control may not actually act alone, because in heavy menstrual bleeding, you might need the presence of oral contraceptive pills. What about the role of IV estrogen? IV estrogen is only indicated when your combined oral contraceptive pills are not tolerated. Patient is so much hemodynamically unstable that she cannot take it orally. Only in those conditions you need to consider that. And the biggest risk of conjugated equine estrogen is the risk of thromboembolism. So you need to keep that in mind. The other concern, when you're thinking about oral contraceptive pills, is will it actually affect the epiphyseal closure of these young girls and cause a reduction in their height, or will they prevent her to reach the height that she's actually expected to reach? The literature says that most of the girls have completed 95% of their growth by menarche, and so concerns about the use of estrogen and closure of the epiphyseal plates should not preclude hormone use for the treatment of heavy menstrual bleeding. That means we can definitely use it. So some important points that I wanted to highlight was that whenever you're using the oral contraceptive pills, choose a pill with at least 30 to 50 microgram of ethinyl estradiol. The low dose 20 microgram will not help to control the bleeding. Use the ones with second generation progestogens, because the second generation progestogens actually stabilize the endometrium much, much better than the others. So levonorgestrel or the desogestrel are preferred. And once the bleeding stops, taper it to continue it for 21 days or till the hemoglobin resolves. So you can give it continuously for the first 3 months so that the HB improves to 10 gram and then make it cyclical or 21-day cycle. If the bleeding does not stop in 24 to 48 hours, you need to think about a hematology workup and opinion. IV estrogen, I already explained that there is a high risk of thromboembolism and should be very, very carefully prescribed. We also need to remember that young girls who are taking this much high doses of oral contraceptive pill definitely should be given a co-prescription of an anti-emetic, or otherwise she will not be able to tolerate it and she will discontinue the drug. What about the progesterone treatment? Progesterone is used only when estrogen, in those conditions in which estrogen is contraindicated or cannot be tolerated. The important thing that we need to remember is that in norepinephrine, a bit of it is actually converted to estrogen. So though it is a pure progesterone, there might be some amount of estrogen which can cause a breakthrough bleeding. And also in those patients in whom estrogen is completely contraindicated, NET may not be a good option. What about the Dipo-MPA? The dipomedroxyprogesterone is not a first line, as it is difficult to titrate and there are severe adverse effects. Tranexamic acid has a risk of thrombosis, theoretical risk of thrombosis when it is used along with COCs. So whenever concurrent administration is used, you need to keep that in mind. Other hemostatics like aminocraproic acid and desmopressin are very sparsely used. Regarding maintenance therapy, we already discussed that you need to taper these doses and continue it at least for 3 months. If breakthrough bleeding occurs, it's always better to double the dose rather than actually stop and have a withdrawal bleed. And once she has a hemoglobin of 10 gram or more, you can switch to a 21-day cycle. With progesterones, you can give it in the first 5 to 10 days of the month. With MPA, which is medroxyprogesterone acetate, 10 milligram OD, again 10 days of the month. For a young adolescent, that would be the easiest method to actually remember to take the drug. What about the long-term management? What we need to remember is that it is always better to continue the cyclical hormonal therapy for at least 6 months. You can stop after 3 months and see if the normal cycles resume, but it is always preferable to continue for 6 months. What about the use of the long-term transdermal patches, rings, and LNG-IUS, and the injectable progestrogens? There have been a lot of literature which has come up recently with the use of these long-term methods of contraception in these young girls. And the data shows that along with the bleeding control, since it provides them a contraceptive benefit, which many of our young girls may be sexually active, it can be of benefit to them. But the subcutaneous formulation of MPA, which is the 104 milligram versus the 150 of the intramuscular, can be used in those patients with bleeding disorders in whom an intramuscular injection should be avoided because of the risk of hematomas. But implants are not preferred because of the risk of breakthrough bleeding. With LNG-IUS, we have very limited data and limited research and case reports in adolescents, which have been shown to be of benefit in young adolescent girls with bleeding disorders in whom it's very difficult to control with the other methods. In those women, it can be individualized depending on the requirement, whether you need to do an office or an OT room placement of the same. But along with all these important parameters, we need to remember that these young girls should have lifestyle modifications if they have specific at risk for PCOS, should have iron supplementation, and should have psychological counseling done
because all these factors are extremely important at this age to see that there is no recurrence of an abnormal uterine bleeding. The other subgroup of these women are of these young girls are the PCOS. So the 2023 data of the ISHRE ASRM said that adolescent girls with irregular menstrual cycles are those in whom you cannot pinpoint and in whom you do not have a clear-cut diagnosis of PCOS, can be labeled as at risk of PCOS, and combined COCs can be considered. In them, COCs with 20 to 30 microgram ethinyl estradiol and also metformin can be considered in the profile of the other metabolic risk profile. So this also needs to be taken into consideration. What about the young adolescent girls who present with bleeding disorders? These are the young girls in whom you might have to consider continuous or extended use of hormonal contraception like the pill, patch, and so on. Blood component therapy may need to be considered in consultation with the hematologist. Desmopressin and recombinant factor 8, again in consultation with the hematologist. NSAIDs are preferable to be avoided because they cause platelet dysfunction. In these young women, there have been case reports of LNG, IUS, and systemic hormones being used, especially in those cases who present with recurrent hemorrhagic corpus luteum cyst. So these young girls can be put on this to prevent the recurrence of hemorrhagic corpus luteal cyst. What about the procedural interventions in adolescent AUB? We said medical management forms the first line and the most important protocol as far as the management of AUB is concerned. It should be done only in exceptional conditions whenever the patient is clinically unstable despite your initial measures, when there is severe heavy bleeding warrants and examination under anesthesia, and there is lack of response to medical management. Suction curettage evacuation helps to remove the structurally fragile bleeding endometrium, restore the hemostatic events, and regenerates the integrity of the endometrium. That's well known. Intrauterine balloon has been tried in some of these young girls when it does not respond with the 30 cc Foley's bulb inflation for 12 to 24 hours. It can help to monitor the blood loss in addition to giving tamponade, and the risk of endometrial infection should be also kept in mind in these young girls. Now, what should be most obvious is what is least. So we'll try to simplify all that we talked about now. That in a nutshell, in the adolescent AUB, it's the immature HPO axis and anovulation that is predominant to be considered. Coagulation defects should be kept in mind. Hypothyroidism, PCOS, local injuries, and sexual abuse should always be at the back of your mind, but always rule out pregnancy. In examination, take a proper history, especially the menstrual, medical, bleeding disorders, and a sexual history. CBC, TSH, PT, APTT, and a coagulation study whenever it is indicated. An abdominal palpation definitely important. If you suspect, do an ultrasound to rule out an adnexal mass, and always elicit a detailed sexual history. Iron supplementation along with antifibrinolytics would be good enough in mild to moderate cases. In the severe cases, combined oral contraceptive pills can be used, and in those contraindicated progestogens. Blood component therapy can be considered in bleeding disorders, EUA in very, very selected cases. This is a very good flowchart for the management of adolescent AUB from the ACOG committee opinion. So once you have a patient comes to you with the initial assessment, do a basic vitals examination to be sure that she is hemodynamically stable. Take a detailed history from her depending on using the different tools that are available to us. Order the basic lab investigations, which will include a beta HCG, a CBC, a ferritin, a fibrinogen. If sexually active, screen for the STIs. If evidence of PCOS is there or strong signs of virilization are there, look for or work up for that. Depending on the bleeding severity, decide whether she needs an inpatient admission. If she is does not require an inpatient admission, go in for an outpatient management with an oral contraceptive pill. If estrogen is contraindicated, you can consider the progesterone. If estrogen is the oral contraceptive pill should form the first line of management. And in those cases in whom it doesn't stop with that, you need to consider the treatment with the hematologist, antifibrinolytics and balloon tamponade. On discharge criteria, ask them to follow up within 7 days and plan the maintenance therapy. So maintenance therapy, we already discussed what we need to do. And whenever you're using the COCs, taper them and give them to continue the pills till their hemoglobin builds up. Because if you stop it before that, again, she will come with another episode of heavy menstrual bleeding. I don't know if I've taken you through a roller coaster because I went a little on a fast pace. But knowing is not enough. We must apply, and willing is not enough. We must do. So beyond all these things that we talked about, I think with such an elite, eminent chairpersons that Samartha Ram sir and Grace madam, I would not be right person to give you some take-home messages, because they'll be the ones, I think, who would be able to give us that. I will just leave you with some food for thought. Is it time that we think about adolescent-friendly clinics where these young girls can be managed in a multidisciplinary team approach? Because many of these girls may actually go to the pediatrician, may not come to the gynecologist. So should we sit together as a pediatrician, a gynecologist, a hematologist, a psychologist, a nutritionist to discuss these with them? Shouldn't there be an understanding caregiver? The mothers come with a lot of complaints to us, isn't it? So the caregiver should be understanding. We as clinicians should maintain the confidentiality and privacy. We discussed POSCO in detail, and we need to be non-judgmental and empathetic to the needs of the adolescents. Thank you. Thanks for a patient hearing. I look forward to the comments from the chairperson.
Dr. Elizabeth, it was a very as usual, it was a very wonderful talk.
Thank you.
And I am sure you have thrown so much of light to the darkness of the management of adolescent AUB. Your point on adolescent, at the time of menarche, if there is a heavy bleeding, we should think about the hematological disorder. That point is well taken. Usually we forget about this bleeding disorders when these girls come. And I also appreciate the point of adolescent clinic. That is very important. I think everyone should have that one. And because usually when the children come to a gynecologist, the neighbors will think, they will open the eyes, why she is going to a gynecologist, that kind of suspicion. But then that will clear up, and the patient will, the girls will feel more free to come to a adolescent clinic than to a special gynecology clinic. I think we all should have that kind of, especially in a well-established hospital, there should be an adolescent clinic. And as I am interested in adolescent health education, and this is my favorite topic, and I think you have done justice to your topic. Congratulations once again.
Thank you. Thank you for those pearls of wisdom.
Thank you. Thank you very. Are you able to hear me?
Yes, sir.
Yes.
Thank you very much. A wonderful talk you have given. You have not left anything uncovered. That would like to say, but certain things one question I would like to ask you.
Yes, sir.
In a case where you have failed to control bleeding or a difficulty to control bleeding, in a case of anovulatory menorrhagia bleeding, and to achieve quick cessation of bleeding, can we go for a DNC?
That's what, sir. In the indication for the procedure, that's what we meant by suction curettage.
Yes.
Only in those conditions in whom it is not controlled within the 72 hours of starting, 48 to 72 hours of starting the oral contraceptive, high-dose oral contraceptive pills, and in whom you are suspecting pregnancy or pregnancy-related causes, you can definitely consider. Because once you do a DNC, the fragile endometrium goes, there is a regeneration of the endometrium, and it will help in healing of these cases. So in those unstable patients, in whom, there are girls who come with 3 gram, 4 gram hemoglobin, so sometimes. So those are the young girls in whom definitely you can consider that. But I think that should be in those exceptional cases and not the rule.
But the reason I would like to suggest, there is an unopposed estrogen action. There will be hyperplasia of endometrium, and the endometrial thickness will be very high. And instead of giving a lot of drugs and high doses, which may create toxicity in the woman, we can quickly achieve bleeding by just doing a suction curettage And that's what I would like to suggest. I don't know your opinion. You have told.
Yes, sir. In those extreme cases, that option can be kept in mind. But otherwise, once the endometrium is supported and regenerates, then the risk of bleeding further will
Comes
not
down.
occur. And we need
Yes.
to actually continue it for at least 3 months so that, you know, the endometrium gets stabilized, a hemoglobin builds up before she can go for a withdrawal.
After DNC or suction curettage, we can immediately start
Start on
OCPs.
OC pills. Yeah,
That's
correct.
what I suggest usually.
Yes.
I think that works well. Then I don't think anything to ask from my side to you. A nice, very nice presentation. Thank you very much.
Thank you, sir. A big thanks to the chairpersons and a special thanks to M.C. Patel, sir, and Asha ma'am, and all the very best for your election.
Yeah.
I hear you, ma'am. Asha ma'am, we can't hear you.
I think you are muted, madam. I think they all are muted.
Okay. Hear me now?
Yes.
Yeah, I can hear you.
Madam, can I ask you one question, madam? Madam?
Yes.
Yes.
Madam, you said we give a medroxyprogesterone acetate. But in my clinical practice, we have found that medroxyprogesterone acetate is not that much effective in controlling the bleeding when we compare it to the other progesterone. Even the people, they say you can give a natural mechanized progesterone because they are very much similar to the endogenous progesterone which are produced. But in our clinical practice, whether to control the bleeding or to postpone the bleeding, as far as the medroxyprogesterone acetate is concerned, it is not going to act. So which progesterone is the best as far as the DUP controlling the
norepinephrine is the best, and androgenic progesterone is definitely better.
You start
to
with what dose? High dose and okay, madam. Please continue. Sorry to interrupt you. Sorry to interrupt you at this point of time. Please continue, madam.
No, what you said is right. The androgenic or the norepinephrine is definitely better to control the bleeding of the acute control of bleeding. Medroxyprogesterone acetate is preferable for the regularization of the cycles and not for the acute control of bleeding, actually. But in those patients in whom even NET will be converted a bit into estrogen, and that's why there might be, in those patients, there might be some amount of breakthrough bleeding. So you can give a high dose, 15 to 20 milligram, 3 times a day of medroxyprogesterone acetate to control the bleeding. But as a first line, always we would prefer the oral contraceptive. Only in those patients in whom estrogen is not tolerated or in whom it is contraindicated, you go for the progesterone.
Okay. Thank you, madam. Thank you very much for your answer. Madam, I have another one doubt where the patient has got a recurrent history of infective endocarditis, or let us say that she has undergone some mitral valve surgery or any other heart procedure. So in case if she happens to have a adult, dysfunctional uterine bleeding, we are not supposed to give both estrogen and progesterone because they are going to form the thrombus formation or infective endocarditis, whatever it is. So madam, in that situation, how should we go about how can we control the bleeding?
Tranexamic acid can be used, and then in consultation with the hematologist, we can consider the other methods, which includes the aminocaproic acid and so on and so forth, which are the higher end of the hemostatic agents, in whom you cannot use the hormones. Like sir said, maybe the first line you can again go ahead. If there is an acute episode, go and do a suction curettage and then put them on the antifibrinolytics rather than use the hormones.
Okay, thank you, madam. Thank you very much.
Thank you.
So I would like to thank the respected chairpersons, the speakers, and the respected panelists who are staying along, even though we are very much late. So we have exceeded the program by 50 minutes only. So requesting everyone, please remember us when you're voting. And over to you, Patel sir, for your final words before I end the session.
So thank you all the faculties who have joined this webinar, guest of honor, speaker, chairpersons, and panelists. And special thanks to Dr. Rejeesh. He has helped us a lot as far as all the webinar in state of Kerala is concerned, and of course, Dr. Kalpana Madam also. And I thank Dr. Asha also for managing this webinar very efficiently, effectively, and in a very interesting manner. Thank you, Asha Jain. And just to mention again, humble appeal to vote for me for post of President Foxy and vote for Dr. Asha for post of Chairperson, Food, Drug and Medico-Surgical Equipment Committee, Foxy. Thank you very much.
Thank you. Good night.
Thank you very much.
All the
Good
best,
night.
sir.
Good
Madam.
night.
Thank you.
Thank you for sharing the evening with us. Thanks a lot. Elizabeth ma'am, your slides were very good.
Thank you. Thank you so much.
Very interestingly made as well. Very nice.
Thank you. Thank you so much. Thank you so
much.
Thank you. Good night. And we
Thank
meet
you, good.
again next Wednesday.
Yes, ma'am. All the best.
Thank you.
Yes, sir. Thank you so much.